One, please start here live.
Hi everyone, and welcome to the day 2 of the deep dive into cancer breast. And today we will be discussing on the metastatic breast cancer. We are going to have three different scenarios as we had for the early breast cancer. Apart from that, we are going to have a spotlight session on into something that we always want to discuss. And are our discussions scientific enough? Do we have enough evidence? Because we go so deep into the subgroup analysis, and how should we look into subgroup and forest plot, something that Dr. Sandil will be telling us after Akhil's moderation. Again, I have requested the chat to be open to all participants and attendees, not only the faculty. So, only request to everyone who's listening, and because the chat is now open one, only ask pertinent question, and that can be taken up by the moderator. If everyone wants to ask some every small question, then actually it's a very difficult task for any moderator. So that is the only request to everyone, and all of us are mature enough to do that. It's pertinent question, and I think every moderator will be answering most of your questions during the course of the panel. So without much of a delay, I invite Dr. Akhil, who's a dear friend and from TMH Banaras, and he's doing great work. I speak with him, and we meet quite frequently nowadays, actually, at some meetings, and he speaks of his work, and I'm really impressed with his work, what they're doing in Banaras. And Akhil, it's up to you. You have all your three panelists: Dr. Ajay Bapna from Jaipur, you have Chetan from Pune, and you have
Dr. Krishna.
Dr. Krishna from Bangalore. All three are online, so please start your panel.
Yeah, thank you, sir. Those are very kind words. So we will be discussing some very pertinent abstracts which have come up in this ASCO, and some also from other meetings. So let's go to the next slide. So I will start directly, Ajay Bapna, sir. Now we see a lot of PIK3CA, because we know that PIK3CA is an important resistant mutation. But the problem is that alpelisib, we don't have much. Yesterday also we discussed alpelisib is not a very good drug. We are looking for some better drugs actually. So there is a study, in our study, which was presented in this year ASCO, and it was utilized in the first line setting. If upfront PIK3CA mutation, combine it directly with the upfront treatment. So it was what is your take, sir, with such upfront settings, without CDK inhibitors in the first line? So your take on the in our study.
Yeah, thanks, Akhil. So from the Kaplan-Meier curve, which you are projecting on the screen, it's has shown the median progression-free survival of 15 months, and in the placebo arm, it was 7.3 months. So comparing to the pivotal 3 trials of CDK4/6 inhibitors, the median progression survival is more than 2 years or 24 months in the CDK4/6 inhibitor, if you take it to Paloma, Monarch, or Mona Lisa.
Yes.
So, and having a very excellent safety profile in the first line. So
Correct,
it's
sir.
all oral pills. That is the another benefit of all these 3 pivotal trials. So it could be just, we can take it as one of the option, but
Yes.
not the preferred option.
Correct, sir. Completely agree. Because the additional cost of the treatment, CDK4/6 are now become somewhat cheaper. When a new drug is introduced, it will be definitely much more costlier. These are also the points. But we want to also discuss about PIK3CA mutant patients who are receiving CDK4. Chetan, sir, any comment on that? If patient is upfront PIK3CA mutation, what is your expectation, sir? Median PFS roughly in the range?
Well, median, if the patient is upfront PIK3CA mutation, as of today, I don't change my plan. My plan continues to, I do it only at progression. But yes, I would definitely like to have a PFS which is at least close to the CDK4/6 PFS.
Yeah. So just
If
to
not
highlight,
better.
yeah, I completely agree, sir. Presently, we do not change the treatment, and this is just an option which is coming up, but unlikely we will be able to utilize it for a very long time because of the obvious reasons. But just to highlight, if we see the various subgroup analysis which are coming now, if there is a upfront PIK3CA mutation, the PFS is hardly 10 to 12 months even on CDK4/6 inhibitor utilization in the first line. So that point we should always take care, and we should while we are counseling the patient, it becomes very important, because when we explain that median PFS of expected 2 years and above, and when the patient progresses within 1 year, then it becomes difficult. That's the importance of doing PIK3CA. And the most important point which I've learned during my practice is that PIK3CA is not a dynamic mutation, it's a stable mutation. Comments on this, Dr. Krishna Prasad?
Yeah, I agree with you. So I think this is an interesting study. However, without head-to-head comparison with a CDK4 inhibitor with the hormonal therapy, it's difficult to change practice.
Correct.
Especially because CDK4 inhibitors are much more, I think, tolerable rather than these drugs. I'm not very sure how selective this PIK3CA inhibitor is, but generally we are all more worried about these PIK3CA inhibitors.
Correct. I completely agree. So this is definitely some new data which has come, yes, but it will not change practice for most of us, except in very rare situations.
Can
So
I ask
having
Akhil?
yes, sir, please.
Having a intramuscular injection for so long, it's just not practical.
Correct, sir. Yes,
Yeah,
Saul, sir.
is this patient group not the primary endocrine resistant patient group in this trial?
They have not specified
I
everything,
think
sir.
it is a patient group which was present in this ASCO is those who are relapsed within 12 months of adjuvant endocrine therapy completion. Means secondary, sorry, not primary. It's mainly within 1 year of completion of it. That's why you get that PIK3. It's not a typical naive patient. And that is reflected, I think so, in the standard arm, which is 7.3 months with Palbo and fulvestrant. You get this small PFS. That's my think. I have not read the trial in detail. That's what my thinking is.
Completely agree with your point, sir. If you see the discussion points, why these patients had earlier progression, whether it was endocrine resistance, whether it was PIK3CA mutation or both. So these point is not very clear. So we look forward to the full paper of this article that will give us more idea. But yes, what we know, yes, patients who are having PIK3CA mutations are definitely having poorer outcomes. That is a prognostic marker, but not yet predictive of response to first line treatment in terms of PIK3CA. Next slide. So this trial also led to improvement in some PFS2. So that is what is very commonly seen if patients are on treatments where the drug is effective. There is some improvement in PFS2. This we have learned from the immunotherapy data primarily, and time to deterioration is also improved. Next slide. So it's clear. The cost is significant, as we discussed. Cost of first line CDK in West ranges from $6,000. Thankfully, in India, the cost has significantly come down now with various assistance program. And while this drug is costing close to $15,000 per month, so definitely out of reach for our patients in 99.9% of the scenario. Next slide. So I will come to directly the post-monarch data. I think this is a very hot topic for discussion, and all of us has wanted to discuss about this post-monarch study, especially in terms of the maintain trial, which is also available. This post-monarch data was presented in this year ASCO. Next slide. So again, Bhavna sir, I will request you to highlight about this post-monarch study. This is a very important study, and for the residents and the junior faculties who are attending it, it will be very useful to get your insights into this trial.
So we have a 3 trial post CDK4/6 inhibitor where earlier we were doing the NGSS this time to know the resistance mechanism. So these 3 trials, Solar One, Capitello, and Emerald, however, they tried their best, but the median progression-free survival didn't reach more than 6 months. So they were all within 6 months. So we don't want any kind of such therapy which will have such a shorter progression-free survival. And moreover, the discontinuation rate was very high in all these 3 trials. So we are striving for a trial which is having a low in the lower side effects than all these 3, and having a better progression-free survival.
Okay, so I think the point is very clear. These are specific scenarios Capitello 291 is somewhat a good important trial which we see, and it has come in the ASCO recommendation update as well. So Solar One we have already seen, but it's still not very good. Elacestrant not yet available in our country, but also not available in Europe also. I discussed with various UK colleagues. They told that elacestrant is not available in UK, not available in Germany. So I think it is not yet commonly available throughout the world. It might be available in US. So, but availability is an issue. But we know, yes, elacestrant is a good drug, and likely camizestrant and other drugs trials are already ongoing. So that will be a specific useful drugs for ESR1 mutant. Dr. Krishna Prasad, would you like to highlight about Capitello 291 study? This is somewhat a good study, which I feel, and capivasertib seems to be doing somewhat better than the rest.
Yeah, I think this is a very interesting study. So they took patients with mutation in the pathway AKT P10 PIK3 pathway, and they found that patients who had mutations in this pathway had significant benefit compared to patients who did not have any mutations, even though as a trial as a whole, the whole group, whether with the mutation or without the mutation, everybody benefited. But the major benefit seems to be patients with mutations in this pathway. And I think based on this, the approval is for patients with mutations in the pathway.
Yes, completely agree. So this is a very important point. These pathway X6 inhibitors and Capitello 291, that is capivasertib plus fulvestrant, that has become a important ASCO breakthrough, and it was presented. There was an ASCO article which was dedicated for this study, and that is why we find that it is an important drug. Since we have multiple trials ongoing with capivasertib in our center, we have some good experience with utilization of capivasertib, first-hand experience. Capivasertib, good point is that significant hyperglycemia occurs in only 10 to 12% of the patients, while we know with alpelisib it is everyone knows it is around 70 to 80% will develop significant hyperglycemia. Apart from that, fatigue and some amount of transaminitis is there, but otherwise it is somewhat much better tolerated drug. The drug has a schedule of 4 days on, 3 days off, which is also we are also utilizing alpelisib in the same schedule now. Previously we
Yes,
used to
and
utilize
most of us.
alpelisib. Yes, I think we
Most of
all
us.
agree. We utilize the similar schedule as capivasertib now for alpelisib also, since capivasertib is not commercially yet available. So let's go to the next slide. And also just to highlight, a Capitello 292 study is ongoing, which is for primary endocrine resistance, and that is also recruiting at our center and some other centers in our country. So
Yeah,
it will be interesting. Yes, sir.
Yeah,
So it will be 292. So that will
Yeah.
be interesting to see primary endocrine resistance, which is the most difficult to treat patients, where most of the time we are forced to utilize chemotherapy, whether it will be useful to utilize capivasertib like treatment. So if we see this post-monarch study design, Chetan sir, I would like to get your rapid comment on the design of this trial, and if you think any potential flaws with the making of the study.
I think abemaciclib has shown some activity in CDK, post-CDK progression. So abemaciclib tested with fulvestrant seems to be a decent choice of intervention. And of course, the standard remains fulvestrant either with another drug like a PIK3CA inhibitor or alone fulvestrant. So I'm okay with this design.
Okay, so I think in the chat box we can see where do we place alpelisib. Yes, till the time capivasertib becomes available, it will be utilized, sir, in selected patients. But I think it is very difficult to base. Yes, sir, there is a trial ongoing with capivasertib in multiple centers, and hopefully it will be available soon in commercial basis by next year. So if we see this trial, which is post CDK4/6 inhibitors, there is a utilization of abemaciclib along with fulvestrant versus fulvestrant alone. Yesterday also we discussed fulvestrant alone is not a very good drug in per se because of the various resistant mutations. The PFS declines very rapidly, and it is very we are able to give hardly 5 to 6 months of PFS. So Bhafna sir, your comment on single agent fulvestrant in the second line?
No, the median progression-free survival is very less, and there is no data alone to use the fulvestrant. So it's no point discussing even this.
Okay, sir. Okay, thank you. Next slide. So if
Another,
we s-
previous slide. So previous slide. So
back,
another highlight of this trial I found was that since we all have started using CDK4/6 inhibitor in the adjuvant setting, so this makes sense to look at this trial because progression
yeah,
post
sir.
adjuvant we can have at least a very good option.
Yes, sir. So this is another very important point. If patient has progressed within 1 year of adjuvant CDK4/6, then what to do, whether it can be utilized or not. So such points are actually very important with the increasing use of adjuvant CDK4/6, both
Because in most of
Rebo.
the meeting, the last question is always what to do if you are using it in adjuvant settings. You have answer.
Yes, sir. So this is one of the answer to be utilized. Next slide. So if we see the visceral metastasis, this is what we see. The patients in the second line settings have significant amount of visceral metastasis. You can see 60% in both the arms had visceral metastasis. Bone only disease was only in 20%. So this is what happens in the real world, even in the trials in the second line settings, post CDK4/6 inhibitors in metastatic setting. And here a very small number of patients had received adjuvant CDK4, but yes, this happens in the now then use had increased. And another important point is previous CDK4/6 inhibitor in this trial was primarily palbociclib, 60% of the patients. And if Rebo, it was 30%. So 60 plus 90% are on palbo or Rebo. Only 8% in both the arms are post abemaciclib. So that is a good point which must be taken into consideration before moving further. Next slide. So this is what we see. There is some prolongation in the PFS post CDK4/6. Bhavna sir, your comment?
Yes, the interim analysis done by the investigator has shown these results, and the median progression-free survival, which they projected, was 6.0. I think I'm sure that you will be showing the blinded investigative central review also later on. So it was very different from what the principal investigator assessed progression-free survival. It was just double of what was the investigator assessed PFS.
So what we see as highlighted by sir is that there is some increment, but whether that increment is actually clinically meaningful, that we need to discuss and decide. Hazard ratio is 0.73, reaching close to 1, but there is some minor improvement in the PFS. And if we see the comment from the investigator, the greatest benefits was seen in patients who had previously received prolonged benefit the CDK4/6 inhibitor. So this is what we do in RCC also, where the patient received a prolonged TKI are likely to respond again to a second TKI. That is what we see. Similar comment is coming here as well. The patients without visceral metastasis, prolonged good response to the first line treatment are doing better. So in a selected subgroup, this is definitely an option. That is what I understood from the and reading this paper. Next slide. And
can I ask a question to the
yes,
panel?
Sir.
Can you go back one slide? So why was there? I think there was a difference in the investigator assessed PFS and the central PFS. Oh, and there is a gross difference actually in the numbers. Anyone knows why this has happened?
Yeah, I think it's because of some censoring issues
that happened in the central review.
Yeah, it was affected by some informative censoring, is what I remember reading.
Dr. Sendilo, anyone who knows, because there's a gross difference in this.
Yeah, double almost.
Yeah.
I just don't know, sir. I'm just not too sure. We discussed about this in the best of ASCO also, if I'm not mistaken.
Yeah, and we are not sure still.
The interesting part is 6 months became 12 months for the abemaciclib arm. But the 5.5 months remained 5.5 months for the... correct. So the hazard ratio jumped from 0.75 or something to 0.5 something. DICR versus the investigator assess. I still don't know. I'm not sure, Krishna, that informative censoring can explain that. That probably can't.
Yeah, I
that
think there was some issue there. I think 51% of patients with abemaciclib plus fulvestrant, there was censoring. Whereas in the fulvestrant monotherapy arm, there was 38%. Some issue there.
But usually we see the opposite. But here it's the opposite in a big way.
Yeah, that's because there was difference in the censoring between the two arms as well.
Okay, we can move on.
Yeah. I think there's definitely some issue which is related to some statistical censoring. There seems to be, but And as Sahu sir highlighted, this is just exactly opposite of what actually happens in the routine practice. The investigator assessed PFS is usually larger and the central review is usually shorter. That is what we usually see, but here it is completely opposite, and the difference is also very gross actually. Next slide. So just very
So at the
quickly-
face value, which one needs to take into the clinical practice?
So I think, sir, if we think there is definitely some improvement if we utilize continuation of that CDK4/6 inhibitor, but it depends. Here I wanted to compare by this slide whether you will utilize post-monarch or would you Lunox maintain trial. So now there are two options. So Bhavna sir, your take on the comparison of these two trials, where it was where we will utilize abemaciclib, where we utilize ribociclib. So
Actually, the forest plot which was shown for the post-monarch study, it has benefited whether the patient was previously exposed to palbo or ribo or amoeba. The investigator assessed progression-free survival was not in favor of the ribociclib. But when it was a blinded independent central review, it showed that it benefited all the three CDK4/6 inhibitor progression.
yeah. So point is very clear. So it seems that abemaciclib is definitely a strong and potent CDK4/6, having a good activity on CDK4. So that is why it seems to be working in all the three scenarios. And the point is that in maintain trial, there were 85% patients post prior palbo. In Monarch, it was 60% palbo, 33% ribo, while abema is just 8% in Monarch and 2% in maintain. So Chetan
Only
sir,
difference, I
yeah.
didn't understand that when we were using it in Monarch in the first line, it helped the patient who had visceral metastasis. But same patient which progressed on CDK4/6 inhibitor, it didn't help patient who are having visceral mets.
So I think,
So
sir,
even amoeba is helping.
yeah. So I think the
It's only
reason,
the non-visceral.
yeah, I completely agree, sir. The reason seems to be a very huge number of patients in that
Yeah.
Monarch study, and here post-progression trial as having a smaller number of the patients. That will underscore the benefit in subgroup analysis. So that is what we see. And these
Akhil, can I
patients,
just ask a question?
yeah, yes, sir,
So,
please.
if we are thinking about this combination in this setting, where do we place everolimus plus fulvestrant?
So, Chetan sir, any comment on this, where we should consider Evro plus fulvestrant?
So typically, I offer everolimus plus either fulvestrant or exemestane after failure on CDK4/6. Alone fulvestrant, my experience has not
Yes,
been
sir.
great. So I
Yes,
try
sir.
to club it with something. And everolimus is quite for people who tolerate it, it does work. There is a subgroup of patients whom we are yet to identify with some means,
How to?
but they do very well with everolimus. So for second line post failure of CDK4/6, everolimus is my go-to drug.
Okay, okay. So I think the point is very clear that there is no very easy way to select the patients whether you will give everolimus, whether will do the second CDK4/6 inhibitor. Any comment on that? Anyone, Vapna sir, how will you select
Yeah,
the patient?
so most CDK4/6 inhibitor, previously we had option of Bolero 2 or Precog 1 study. Precog used the fulvestrant and everolimus, and Bolero 2 used exemestane and everolimus. So Precog, the combination of everolimus with the fulvestrant didn't work, but exemestane plus everolimus combination worked.
Yeah, okay.
Yeah.
So I think again it is slightly difficult to exactly answer which one will benefit where. But yes, everolimus, as Chetan sir highlighted, those patients who respond and tolerate everolimus, it is a very good drug for them. But some patients do not do well on it, and they have so many issues. So in those patients, if we started everolimus and they are not tolerating, we can switch back to another CDK4/6 like either Ribo or Abema and continue fulvestrant. And I think everolimus seems to be a good option based on the available drugs. If capivasertib becomes available, that will change the way we treat, but it will be specifically for the AKT3 mTOR path. So everolimus is also targeting the similar pathway. So it can be called a poor man's capivasertib. I think saying that thing.
Yes, yes, absolutely.
Yes, sir.
Covering the same pathway.
Covering the same pathway. Yes, sir. Next slide. I think we'll have to see the difference. So post monarch, it was just 0.7 months FPFS. If we see the investigator initiated, what in maintain was 2.5. But if you see the placebo arm in the post monarch, it done better than the placebo of maintain. That is one point which I wanted to highlight here. 2.8 months PFS in placebo arm in maintain, while it was post monarch 5.3. That led to significant less difference, quantum of difference between the groups in maintain and post monarch. So that is point. Next slide. So this is what we have already discussed, so I don't need to discuss it now. Next slide. So this is where we see if there is actionable mutation PIK3CA, you can utilize capivasertib. It is not feasible, or if you don't get any particular mutation, everolimus is an option versus switch CDK inhibitors along with endocrine therapy is an option. If we get AKT-P10 pathway, definitely capivasertib when becomes available, it will be a good drug. ESR1 elacestrant, and otherwise the ongoing trials, camizestrant trial is being started at multiple centers. Hopefully this will be a good option for us. So this is the summary, what we have to understand and do now.
So it's a switch CDK4. You would not continue the same
Yes.
CDK. So you will change the skeleton also and the other part, the CDK also.
Yes, sir. This seems to be the case. The reason being, in both the trials of maintain and monarch, we saw that very less number of patients were on the same drug. In the post monarch, only 8% patients were abemaciclib. In the this maintain trial, there were some patients, it was slightly higher than the abema, but still 60+% patients were on palbociclib. So it is primarily post palbo. That is what I understand from my understanding. Dr. Chetan sir, do you agree with this comment?
I do.
Yes, sir. Yes, sir. Yes, sir. So I think I tried to cover about the most of the pertinent abstracts. There are many more, but I think with the available time, this is fine. Sahu sir, you want to discuss anything else?
You can take the chat actually, and I think there is a question on Sonia. I don't think it is pertinent, and if Sonia comes in, it was a time. I think it is pertinent only when the cost of the drugs were more and we did not have anything beyond. Should you use a CDK4/6 upfront or on progression? I think Sonia only answered that point, how the panel thinks, because there is a question in the chart. The role of palbociclib as first line is questionable after Sonia study from one of the attendees. So do you think it is the right question to ask even? Could you not offer CDK4/6 for everyone now who is eligible in upfront?
Bhavna sir, what do you think?
I think Tarini has already explained that Sonia trial hasn't helped us much because we want to gain the benefit of progression-free survival in the first line, and that we cannot get it in the second line. It is just half when we use the CDK4/6 inhibitor in the second line. If at all you have to use it in first line.
Yeah.
And take the advantage of progression with survival of nearly 2 years.
Sonia was, if someone has really missed and someone has not been offered the CDK4/6 in first line, Sonia gives you a reassurance that you have to use CDK4/6 and no one should ever not now receive a CDK4/6 in this subset of patients. So it makes.
But who misses Sahu in the first line? Nobody misses these days in first line.
Yeah, no, if that is
so Sonia doesn't make sense to me at all.
Yeah. I think with the new drugs, it is there. I think that is how.
Yes. Yeah.
Any other questions, sir? Sahu sir, if you see.
No, you have to take it. If there is anything or anyone wants to ask anyone anything, that we can just. The take home which I felt you told us was after you progress on a CDK4/6 and frontline, do a NGS. I hope that was what was taken home as a take home number one. Yes, and once you do NGS, you look at the mutations which you get and then you start selecting. If you have a PIK3 AKT pathway, then capivasertib comes into the affordable patient. And if there's a PIK3 mutation also, you would be discussing alpelisib versus capivasertib. So these two are
Yes.
options. That's what I came to know.
Correct,
If
sir.
there's no mutation, then comes in the point of adding something to fulvestrant or CDK4/6 beyond CDK4/6.
Yes.
So no CDK4/6 for anything that has a mutation beyond progression. That's the take home from you, Akhil?
Yes, sir. Completely agree.
Okay. Okay. Anyone wants to add something from the panel? Chetan or anyone? We have 2-3 minutes on your panel, so we can utilize that.
So I missed, Sahu, what was what you wanted to say?
My point was what Akhil's last slide, which is on the screen, tells us that we need to now do NGS and look at the resistant mutational pathways after we have failed a hormone therapy / hormone plus CDK4/6. And once we
No, I think assessment of resistance mechanism comes now in the third line, because we have seen in the post-monarch that all the mutations, ESR, whether it is ESR1 PTEN or PIK3CA, it worked beautifully in all these mutations. So the resistance mechanism we need to know only on post-monarch progression.
No, Akhil, do you agree to what Bapna sir is saying?
Sir, point is that if there is no accessibility
It
to
covered all mutations.
capivasertib, elacestrant, if you see the majority of the drugs are presently not accessible. So that is why I think
if the drug is accessible from next year, we know capivasertib is going to be launched.
Going by the available by the literature, I think we can do NGS post.
We should be pushing for NGS.
Yes,
okay.
Yes.
I think there's one more minute, and there's a question which in the chat which the panel can take in. I think Dr. Suresh, CDK4/6 adjuvant, we spoke about it yesterday, and we had a full half-an-hour panel, and I think we will send the recordings and you can look at. Any role of tamoxifen with CDK4/6 after progression with a first-line AI or fulvestrant? And I expect the person is asking, they have not received any CDK4/6 before. Anyone? Maybe Krishna or Chetan? Anyone? TAM with CDK4/6 after progression with AI alone. Akhil, you can take it.
So I think, sir, it is just a jugglery of the drugs. If it is not utilized and other drugs are not feasible, then it can be considered. But I don't think there is a very strong action on any evidence-based data for the same.
You can use it, but you would be skeptical, and none of us prefer it. Is the problem?
Yeah, correct, sir.
Okay. So I think there is one trial. If there's a question,
sorry, can you please repeat the question?
Yeah, Chetan,
what was your
question to you? In a visceral crisis, would you now today do chemotherapy, or are you comfortable with the responses we're looking at in the early onset of response to do CDK4/6 plus hormone therapy? Chetan,
I'm sorry, I can't hear you.
Chetan, are you able to hear me?
Your voice
Can
is breaking.
I answer that, Sahu?
Yeah, please. Bapna sir, can you ask the question?
Yeah. So in visceral crisis with very good performance status, we have Shaina Dawood's data, which was presented at ASCO 2022, and it has given a good, median progression-free survival of 6.5 months. Not bad.
Yeah. So it's the right protocol, right trial or something like that.
Right choice study.
Yeah, right.
So Shahina group had presented it in ASCO 2022, and it was well taken.
I think that answer is in the question in chat. So now we have data, although not the best level of data, but because the AIs and the CDK4/6 responses are quicker and stronger and deeper. And if you look at the response rate, they're actually much better than chemotherapy in this subgroup of patients. So you can
only the word of caution is that tamoxifen shouldn't be used with ribociclib.
Yeah, agreed, for the toxicity part of it.
Yeah. So I think for visceral crisis, there is now enough evidence to support the use of CDK4/6 inhibitors, especially the drugs like Ribo and other drugs.
So last question we'll take from Amita, and one of the panel can answer. Chetan, if you can hear me. CDK4/6 plus endocrine therapy, patient is on, only brain mets, no systemic progression. What would you do, Chetan? And then probably Krishna. Chetan, are you able to hear me now?
Yeah, I think Chetan cannot hear. So
okay, please.
I think if there is a solitary brain met, I would definitely get a neurosurgical opinion. especially if there is a long progression-free survival.
Okay, perfect. And I think that question is now answered. Chemotherapy, at least nowadays you feel, except for maybe 2 or 3 lines, and then you can do chemotherapy, especially if the failures are much quicker for 1 or 2 lines, then I think chemotherapy comes in earlier. If there is a good response to each line of therapy of hormone, you would like to push that hormone therapy a little longer. Darshan, I think that's the question, we answered that. And Chetan has already spoken about that PFS is a valuable asset to choose the second line treatment. So I think that is it. Thank you, Akhil. Thank you, everyone. And congratulations to all of us. India won the bronze again. So Srijesh gets a farewell gift from the Indian team in the hockey. We have won the bronze in hockey by the time you are doing this panel. So congratulations to everyone. So now we move on to the next thing. And Dr. Sendil, I think as Akhil's panel really boosted Indian team, you will boost Neeraj Chopra to win the gold today. Dr. Sendil, all yours.
Thank you, Sahu. I hope that will happen. And then if that happens, will you call me every time you host a meeting?
Every time.
Every time? Okay.
I call you every time. That's the honest answer from my side.
Okay, super. Good evening, everybody. And thanks, Sahu, for asking me to do this talk. For some reason, Sahu felt that I might be one of the most appropriate people to do this talk. I'm still not sure why. But I thought, let me take this up as a challenge because I consider myself a self-taught statistician. I've not been to a course. So I kind of try and read up and make sense of whatever forest plots or any other plots that we see in these papers. So what we will do today is to try and understand what's the best way to analyze a forest plot, which typically represents a subgroup analysis. Now, let's start with some numbers, which are actually very dismal. Now, this is a subgroup analysis of ASCO meeting in 2020 and 2021. Now, the point here is that they looked at 1,344 individual subgroups in 81 forest plots. 57% of them were inconclusive. 41% showed evidence of treatment homogeneity. That means the effect for the subgroup is the same as the effect for the main trial itself. That means if the trial is positive, then the effect is also positive for the subgroup. So 40% showed treatment effect homogeneity. 1.6% yielded evidence suggestive of treatment effect heterogeneity. But what we generally do is we kind of misinterpret forest plots and mix up homogeneity and heterogeneity. So it's only a very small proportion of these subgroups that actually are in contrast to what happens in the main study itself. But we sit in our panel discussions in all these meetings and split hairs and try to dissect through and look for heterogeneity, which rarely exists. This is even more appealing. This is 785 trials, more than 3 lakh patients. The credibility of differential treatment effect claims was rated as low or very low in 93% of all cases. So when you're saying that the effect for a particular subgroup is not homogeneous, or easy to say will be that it is heterogeneous, the likelihood that it is robust is very low most of the time, but that's what pharmaceutical companies, moderators, panelists, most of the time come to a conclusion as. So what we will try and do in the next 15-20 minutes, and we'll have some time for discussion, is to see what are the parts of a forest plot, how is it to be represented adequately and appropriately. That's point number one. The second thing we will do is to try and look at some criteria that we can use in order to establish both credibility and the robustness of a representation in a forest plot. We'll then go and try and interpret some of the forest plots that we kind of debate upon in our meetings, and then finally end with the summary. So that's what we will try and do in the next 20 minutes or so. Now, this for me is a very ideal representation of a forest plot. This is Dr. Sudeep Gupta's presentation in SABCS 2022. This is the effect of platinum in triple negative breast cancer. This is subgroup analysis represented by a forest plot for disease-free survival. Now, what are the parts of this forest plot? You start with the subgroups. Now, there's age, menopausal status, family history, and so on and so forth. There are 6 variables that have been represented here. And they're very standard variables that have been chosen. That's very important. Now, the next column tells you the total number of patients in the platinum subgroup. How many of them had events? So 255 were the total number of patients, less than 50 years, 71 of them had an event. In the control, there were 245, 98 of them had an event. So this is the 5-year event-free survival. This is percentage in the platinum and in the control. So that's very important. Now here comes the crux of the whole forest plot itself. Now this tells you the point estimate for the study, which is very important to be represented as part of a forest plot, and we'll soon learn why. Now this is a hazard ratio, that's 0.798. That's the confidence interval. So that center point represents 0.798. That is the confidence interval from 0.62 to 1.02, just missing significance. And then you have the hazard ratios for each of these subgroups. This is called the point estimate. This is called the line of no difference or null difference. So this is 1, okay? And then here you have the hazard ratio for each of these subgroups. And this is something very important when you're looking at a forest plot. 9 out of 10 forest plots that are represented, even in the best of journals, will not contain a P for interaction. What's the P for interaction? It tells you as to whether this difference in the effect that you're seeing between less than 50 versus more than 50, is that by chance or is it significant? Okay, so this is a very important number that you should look for in forest plots. So let's quickly run through this again. Subgroups, total number of patients in the subgroups, number of patients who have an event, the 5-year event-free survival in the platinum subgroup, in the control, line of no difference, the point estimate for the whole study or the effect for the whole study, that's 0.79, that's the 95% confidence intervals, point estimates, which represents hazard ratio for each of these subgroups, and the interaction p-value. Okay, this is an ideal representation of a forest plot. Now, having understood what is the ideal representation, the next question that we need to ask is this forest plot or subgroup analysis credible? Is this analysis credible? Because then we go and do the analysis of whether this is homogeneous, heterogeneous, and so on and so forth. If you have a forest plot where the credibility is in question, then there's no point in splitting hairs over the numbers that are represented in that forest plot. And this is done by something called as an Eisman criteria. Eisman stands for Instrument for Assessing the Credibility of Effect Modification Analysis. Don't worry, it's just for you to know what Eisman is. So remember Eisman. What are the points that you look for when you are analyzing a subgroup? The first question is that this subgroup analysis has to be pre-specified at baseline and powered to answer the question that you're trying to ask. Okay? Pre-specified at baseline and powered. Also important is to have an a priori hypothesis of why you're actually trying to ask this question for that subgroup. And based on your biological explanation, also try and say which direction is this likely to go. Okay, so you pre-specify the subgroup. It should be powered to answer that question. You should also have an a priori hypothesis as to why do you want to analyze this particular subgroup and what is it that you're expecting in terms of the outcome for this subgroup. So this is very important to look for either in the protocol which comes in the supplement or as part of the statistical analysis that is there in the main paper itself. You rarely find this, and you can take my word for this. The second important point is to look for the interaction test, which we discussed in the previous slide. Is this by chance association or is it robust? Is this explanation unlikely or is it true? So look for the interaction test. The other very important thing is the number of effect modifiers tested. Remember, I showed you the previous forest plot and we said 6 variables or modifiers were tested. There was age, there was menopausal status, there was stage, and so on and so forth. So the number of modifiers tested is very important. The higher the number, the less is the credibility. Okay, we'll look at in the next slide as to what is that ideal number. So the number of effect modifiers tested is very important. The higher you test, the more is the likelihood that you're going to end up with a false positive result, especially in a very important subgroup. If you're finding a homogeneous or a heterogeneous result, the question that you will have to ask is this effect modification present in a previous randomized control trial? A standard example is, let's say, an EGFR TKI and L858R mutation. You'll always find that patients with L588R have a slightly poorer outcome compared to exon 19 deletion. So if you're finding it in another study, you go back and ask the same question, is this happened in a previous study? Because if that effect is very consistent, then adds credibility to your subset analysis. Very important again, if your modifier was a continuous variable, for example, age is a continuous variable, PDL1 is a continuous variable. Remember that when they are looking for the subgroups, you need to make sure that you're taking standard cutoffs. For example, in the previous one, I showed you less than 50, more than 50. That's a standard cutoff for breast cancer. Let's say if Dr. Gupta went and did less than 40 versus more than 40, then that is suspicious because he wants to then show some positive result on his subset analysis. But he did the right thing by choosing less than 50 versus more than 50. If you're looking at PDL1, it should be negative 50 or beyond. You cannot suddenly get in and say, I want to look at PDL1 27 or more. You know, that's suspect. So this is very important because this uncommon cutoffs are usually based on post hoc analysis. You go and do salami signs, you kind of torture the data and get some positivity and then go and say, this is the subgroup cutoff that I want to use. So this is very important to keep in mind. So broadly, subgroup analysis can be inferential. Now, when is it inferential? If all these criteria are satisfied and then you're saying this result is robust. So pre-specified at baseline, powered, you have an a priori hypothesis, and so on. It is supportive when you have pre-specified a subgroup analysis, but you haven't powered it. Remember that many of these articles will say age, L858R, CNS metastasis was pre-specified subgroup analysis, but they will not tell you as to whether it is powered or not. So when it is not powered, it's only supportive. That means you look at the previous studies and say, okay, this is the same I'm getting in this study also, so I probably will agree with this. Most of the time, it's exploratory. Okay, so exploratory can again be pre-planned. That's not very different from supportive. That means you're planning something, but you're not powering it. You don't have a clear hypothesis as to why you're doing it. Post hoc is always torturing data and going back and doing, a lot of subgroups, which I will show you exactly as to what it is and why you shouldn't do it. So inferential, supportive, exploratory. So those are some subgroup analysis that you can classify as. Now, again, people get confused between stratification factors and subgroup analysis. What is a stratification factor? A stratification factor is a variable that you will use to make sure that it will not confound the results of your study. For example, if you have age as a very important stratification factor, during randomization, you will make sure that groups of people in that cohort of age are equally distributed between the two groups, the standard arm and the test arm. So you're trying to make sure that your randomization will be appropriate and it will make the influence of confounders as least as possible. That's stratification factor. Usually you'll have 2 or 3 stratification factors for most big randomized studies. Okay, so stratification factor is not a powered subgroup analysis. Keep this at the back of your mind. So this is how it should be. Very busy slide. Just look at the areas that I have underlined it. This is an extension of the Eisman criteria. We looked at multiple criteria. We start by asking, was the direction of the effect modification correct based on hypothesis? So I said you need to define it a priori. You can't do it post hoc. Was the modification supported by prior evidence? We took the example of L858R versus exon 19 deletion. The third point, I think, is an extremely important point. Now, when you're doing an interaction p-value, you always do something called as a multiplicity analysis. Remember that the alpha, okay, the p-value for easy understanding, an alpha that we generally agree upon is 0.05. Now, you have to use this 0.05 to look at multiple analysis. You can't look at a 0.05 for each of these analyses. So when you're doing multiple analysis, you need to do something called as a multiplicity correction. Only then that power is adequate and the p-value that you're getting for that particular subgroup analysis is adequate and appropriate. So remember, the interaction p-value for a robust interaction test is not 0.05. It's not 0.05. It is less than or equal to 0.005. How do you get that? There are many ways of getting there. One of the easiest ways of doing that is you divide the alpha, which is always 0.05, at least most of the time 0.05, by the number of subgroups that you want to analyze. Okay, 0.05, for example, in Dr. Gupta's trial, the best interaction p-value should be 0.05 divided by 6, which will actually be 0.008. We'll come to that interaction test in a moment, again, when I analyze that forest plot. Okay, so if you have an interaction p-value of less than or equal to 0.005, that's very robust. Remember this number 0.01 to 0.005 because I'm going to interrupt that. I'm going to interpret that forest plot soon. So this number will be useful for you when I do that analysis. So if it is less than 0.01 and up to 0.005, chance may not explain. Still, it's reasonably robust, but not the best. Look at the number of subgroups that you ideally should be testing. It's 3 or fewer. I cannot remember a randomized study where 3 or fewer were actually analyzed. Okay, it's always, almost always 6, 8, 10, 12, 18. I'll show you something where 19 subset analyses were done. And then we spoke about the number continuum, whether it's age, PDL1, and so on and so forth. So this is to tell you if you're satisfying the best in terms of the criteria that are described here, then the effect that you're seeing is very highly likely. If all of them are towards the left, that means there's definitely no column in this slide, then the probability that your interpretation is correct is very, very low, as we saw in the initial slide regarding our interpretation, the author's interpretation, which is very, very poor in terms of the subset analysis. So what are the other ways of really looking at this interpretation? Now, this is from the article about that ASCO, subgroup analysis that I showed you earlier. Sahu, please tell me when I have 5 minutes to go. Okay. So this is an interpretation of the forest plot from that ASCO study that I showed you during the beginning of my talk. Now, this is a standard forest plot. It's giving you all the constituents of a forest plot. We start with the point estimate here. Okay, so the point estimate here is 0.58. So that's where it is. This is the line of no difference. So what they're suggesting is that you construct a zone of indifference, which is 80 to 125 of this 0.58. So this shaded area is 80 to 125. This is easy to construct for any of the forest plot. You don't need to be an expert statistician to do it. If I can do it, you can do it. Now, very important, there are 3 things that you can describe based on this construction. Either your subgroup analysis is inconclusive, the treatment effect is heterogeneous, or the treatment effect heterogeneity, which means that the subgroup result is contrary to the main result. You see that the main result here is in favor of the treatment group. If it's heterogeneous, that means it is not in favor of the treatment group. It actually favors the control group. What is treatment effect homogeneity? That means it follows the rule. That means the effect of the treatment in that subgroup is the same as the effect in the total intent to treat population. Easy way of interpreting this. The first thing you need to look at to say that the treatment effect is heterogeneous or it's going in the opposite direction is that your point estimate should jump to the other side of unity. If it's not there, then you cannot clearly say that this is heterogeneous. The other criteria to say it is heterogeneous is that the lower limit of this confidence interval should not touch this point estimate. Okay, so the lower limit of this confidence interval should not touch this point estimate, which is 0.58. Only then you can say the treatment effect is heterogeneous. Anything else is homogeneous or inconclusive. Look at this. It's on the other side, but the lower limit of confidence interval is touching 0.58. So you'll call this inconclusive. This is not lack of effect or favoring the control group. Remember, this is commonly what we would do in our panel discussions. The point estimate went to the other side. So I'm saying that this is lack of effect. No, this is inconclusive. Look at, again, this is inconclusive. This is falling on the same side, but you see that it's exceeding this zone of indifference. Okay. Now, I put this reference at the bottom here. This will take some time for you to sit and look at this and go through this many times before you really understand this. But it is very easy to apply when you're doing your forest plot analysis. This is in Therapeutic Advances in Medical Oncology 2022. The first author is Andrew Hand. It's a very nicely written paper taking multiple examples here. So this is the way you interpret a forest plot. Not just based on the upper limit of confidence intervals going beyond 1 or the point estimate going to the other side and you saying that this is the way we will interpret it. Excellent. Let's now come back to Dr. Gupta's lovely plot. Okay, ideal representation of a forest plot. Let's apply the Iceman criteria here and then see how credible this is number one. And then how robust is this heterogeneity that you're seeing for age and menopausal status. So let's start here. Look at the number of subgroups. Age, menopausal, so there are 6. It's not wrong to do 6. Ideal is 3. So we will mark that as a tick. Has he used the usual cutoffs or the described cutoffs for these patients? The answer is yes. Less than 50, more than 50 is standard. Premenopausal, postmenopausal is standard. All the other criteria that are there in the subgroups are standard divisions. So both of these are ticks here. Number 3, let's use the previous analogy in the previous slide that we spoke about heterogeneity, homogeneity, and inconclusiveness. So is this heterogeneous? The answer is yes. Why are we calling it heterogeneous? First thing, the point estimate is falling to the right of unity. And you look at the lower interval of this, lower limit of this confidence interval, it's 0.82. The point estimate here is 0.79, just missing, but it is heterogeneous. Okay, it is not homogeneous, it is heterogeneous. So there is an opposite treatment effect, or the treatment effect says that the control is actually better. What about pre and post menopausal? Again here, let's apply the same rule. The point estimate is to the right of 1. Which means the control is better. And this lower limit of confidence interval is 0.80, just beyond 0.798. Okay, just beyond. It's like Poget's 100 gram, right? It's something like that. It's less. So it passes the test of saying that this is heterogeneous. Okay, criteria number 1, subgroup, we are okay because not too many have been analyzed. The cutoffs taken are standard, so we are okay with that. There is heterogeneity based on what we described in the previous slide. Number 4 is the interaction p-value. The interaction p-value here is 0.01. Again, let me say this, that this is not published, so I don't have the full statistical analysis. I'm just basing my interpretation on the slides that are available in the SABCS website, or the one that I got from Dr. Gupta himself. So there may be more to this forest plot than what I'm saying, but this is based on my simple interpretation. If you apply the Bonferroni correction here, 0.05 by 6, ideally this should be a 0.008 p-value for interaction, But this is 0.01. Remember, I said in that Iceman slide that anywhere from 0.01 to 0.005 is still acceptable, that this is not by chance. It's very unlikely to be by chance. Okay, if it was 0.008, I would have said this is certainly not by chance. Now, I'm saying it's very unlikely to be by chance. Okay, so this p-value is good, but we would have loved to see a lower p-value here. And then 5, most important, we said, is this replicated in other studies? Are there other studies of platinum where the same thing is happening? There's a nice Cochrane database, Cochrane analysis of this. Cochrane analysis is not showing heterogeneity in terms of age and menopausal status. So this is the only study that is showing that. So that's a minus point here. Can we biologically explain this difference? This is not hormone positive disease to have some difference between premenopausal, postmenopausal. Age might have some impact, but the menopausal status in a triple negative breast cancer, looking at the effect of platinum, should not have this change. And we have all discussed this in our meetings, including Dr. Gupta himself. We're not clear about why this heterogeneity is there. But this heterogeneity is something that we cannot ignore based on the Iceman analysis and the interpretation of the forest plot. So they are doing some molecular analysis to see whether they can explain this heterogeneity, but we don't have any news as of now. So this is a good representation. It's a rightly concluded forest plot. This heterogeneity that you're seeing is very less likely to be by chance, but we would have loved to see a better p-value. So that's how we would interpret this. If you see a forest plot like this, you don't have to waste any time on this forest plot. 17 subgroups have been analyzed. It's better we move on rather than wasting time. You may split hairs over all these subgroups, but there's no meaning to any one of these. This is called a $1 billion forest plot. Okay. What is this side? So do I have 5 minutes?
1 minute. You have 7 minutes.
7 minutes, lovely. So then I'll go slow. Okay, so this is called the $1 billion forest plot. Okay, now this is pemetrexed platinum versus gemcitabine platinum in non-small cell lung cancer, advanced non-small cell lung cancer. Now, all of us today use pemetrexed and carboplatin for our patients with adenocarcinoma, and this is the study based on which we came to that conclusion. Now, based on this forest plot, is that conclusion right? Because ever since this has been published in 2008, we've all changed to pemetrexed platinum, including me. But let's ask this question, is that conclusion right based on this forest plot that you're seeing on the screen? First of all, this is a non-inferiority trial, okay? The progression-free survival for this study, especially in the adenocarcinoma population, was no different. But you're seeing that in this subpopulation of adenocarcinoma, for the overall survival, based on this subgroup analysis, there is a 0.9-month difference with a p-value of 0.03. Now, is this p-value adequate? The answer is no. Based on our Iceman data that I just showed, the answer is no. You have to have a p-value of less than 0.0026 to say that this analysis has been corrected for other covariates or the multiplicity analysis done. How did we get there? 19 subgroups you're seeing on your screen. 0.05 by 19 is less than 0.0026. Okay, so clearly no. Now, interestingly, the FDA label for pemetrexed does not say that it's the best drug for adenocarcinoma. It says that pemetrexed lacks efficacy in squamous histology, which we take as efficacious in patients with adenocarcinoma. It also clearly says that the outcomes in non-squamous, non-small cell lung cancer is not being adjusted for multiple comparisons, which makes the Iceman credibility test for this at a very low level. Is there a biological rationale? The rationale was post hoc. The pre-specified analysis was there, but the rationale was post hoc. They said there's increased thymidylate synthetase expression in patients with adenocarcinoma, and so pemetrexed works better. The only point in favor is that other studies have also shown that in adenocarcinoma patient, pemetrexed cisplatin or carboplatin seems to be efficacious. So there is some data to back this up. And the toxicity is better, and also the administration easier. So if you just base your analysis on this forest plot, you should not be concluding that pemetrexed cisplatin is the best drug for patients with adenocarcinoma. But we tend to do that in practice because of some biological rationale and the other studies also pointing in the same direction. We'll probably do this forest plot and then conclude. This is the latest, right? This is Lancet 2024, poorly represented forest plot. You don't have many of the things that I told you should be there in a forest plot. Multiple analysis, you don't see the interaction P and so on and so forth. So the FDA approved Pembro in patients with FIGO 2014 stage 3 to 4A cervical cancer, but unfortunately not in the 1B, 2 to 2B lymph node positive patients, because they said that the point estimate is here, which is 0.70, is driven by patients in the stage 3 to 4A. Based on this forest plot, you cannot come to that conclusion because this analysis is inconclusive. You cannot rule out a benefit. This was reported at 17 months median follow-up. This is a better prognostic subgroup. You will take much more time to accrue events in this subgroup, so you probably will have to wait. Instead of jumping the gun and then saying that this is beneficial only in this particular subgroup, I've written many reasons why this is not the most appropriate way to do it. Interestingly, there is an overall survival benefit that you can get on this in the Merck's website. And let's now see what happens in September when this data is going to be presented at ESMO and what the FDA will do. Have there been earlier instances where a hazard ratio of 0.9 was approved by the FDA? Checkmate 057 is a classic example. They quoted various reasons, but we're just analyzing the forest plot and then the conclusions based on that, right? We won't get into this. We won't get into Flora. We won't get into Olympia. I'll probably conclude by saying that, remember, ladies and gentlemen, that forest plots, clinical trials themselves are never perfect. You cannot find a perfect boyfriend. Now you can't find a perfect girlfriend. So you don't expect it to be perfect, but it has to be acceptable in terms of what you want to conclude and your interpretation of the forest plot. And when you're seeing a forest plot, it's important to get the right view. So I've tried to tell you what little I know about this interpretation. I hope it will be useful for you in your analysis of the next article that you read and the forest plot that you're trying to interpret. Thank you, Sahu. I hope that was useful for our audience. I'm happy to take questions, if any, if there are any, and if there is some time.
We can take two questions.
Yeah.
And then you can answer a lot of things that are on the chat after we go to the next, within the next panel. So please, two questions.
Amish here.
Yeah, you came in last, but you
I know.
Yeah,
No, I thought, Senthil, you wanted to say something about the cervical cancer, Keytruda, and then I think suddenly the change.
No. I didn't want to take time because we're running short of time. So I wanted to say that the FDA approval based on this forest plot was not appropriate.
Okay. If you had to give the approval, either you would wait or you would give in all comers, or what would you do?
Yes, I would have done either of that.
Okay.
One more, anyone who wants to ask, please unmute and ask. Otherwise, we conclude this.
Sir, can I ask a question?
Yeah, sure. Amol bhai, please.
Yeah, so why is it not mandatory by the journals or the ASCO or ESMO presentation to?
Why is it not mandatory to have the
most of the time
p-value of heterogeneity, the interaction heterogeneity to be mandatory? That's what Amol.
I think there are so many things, Amol, in journals that are not mandatory, including your, what is the censored data, what is the interaction free. They don't tell you that you have to specify everything. So I think it is ideal to have a journal which will ask for all of this, but unfortunately, journals are not the way all of us like it to be. So we need to accept all these imperfections and move on. We'd love them to be perfect, but that's not the way the world works.
Okay.
Thank you, sir.
With that, I thank you, Dr. Senthil. It was a great learning. I think all of us learned a lot. and I think we will involve you in many more sessions on Saturday.
Oh my God!
Because-
So you're going to make me work harder.
yeah, it is, because you make us understand the things so easily. You, Dr. Sudeep, I can tell you these two have been one of the best strategic
So you made my day by putting me on the same pedestal as Dr. Sudeep.
Yeah.
Thank you. I'm
So
going.
please
Krishna
answer those
Prasad, I'm
questions.
not there on your panel.
So please answer that.
Yeah. I'll
Answer
do
the
that.
question on the chat. By the
I'll
time
do
you
that.
are also a panelist for the next.
Yeah, I'll do that.
So we will ask the next panel to please share their slides, and it will be another good friend of mine, and again someone who is not seen that much in the many of the forums, but I can tell you I've heard him many times, and Krishna is a great moderator, and he will pick up and highlight few interesting points. So it's Dr. Krishna Prasad from Mangalore, and he will be doing on the HER2 positive metastatic breast cancer. His panelists are Dr. Sandil, he stays on. Dr. Bharat Vaswani is there, and I see Ghanshyam Dada, so he's also there.
Yes, sir.
Yeah. Please, can you expand your slides, please, and make it full screen and take on for the next 35 minutes? Krishna, you're on.
Oh, sorry. Yeah, thanks, Sao, for this opportunity. It's an honor for me to, moderate this panel, which contains three big men. So I was
men in what
thinking,
sense, Krishna? In size, in terms of...
everybody will know now. So I wanted to ask a very important question first. So an easy question so that the panelists can ease into the discussion. So who is this important man of the day? So anyone can take it. So related very much clearly to the present times and discussion. Unfortunately, is not related to this discussion. He is Norman Pritchard. He is the first, representative of India in the Olympic Games. He was a lone athlete in 1900 Olympic Games, winning 2 medals, both silver. So he's the first Olympic winner for India. Now, nobody knows about him because for Indians, Olympics is only one sport, and it was only one sport for many, many years. And similarly, for HER2 positive metastatic breast cancer for many years, trastuzumab was the hockey. Any HER2 positive patient used to get trastuzumab, and with very good PFS of 25 months compared to 20 months in this landmark study way back in 2001 by Slaman et al. Along came Abhinav Bindra, and then he started adding a new drug, that is Perjeta. And clearly it showed that, adding pertuzumab to trastuzumab improved the overall survival significantly from 40 months to 56.5 months. So with this as the base, so Senthil, if I can go with you first, in this present day and age, HER2 positive metastatic breast cancer, I assume virtually everybody would get a monoclonal antibody. Are there any patients in your practice who will not get trastuzumab, maybe with pertuzumab?
There are patients who still don't get pertuzumab, Krishna, but almost everybody, I would say 98% would get some trastuzumab. Beg, borrow, steal, but some trastuzumab.
And what is the percentage you are actually getting trastuzumab plus pertuzumab?
Let's say 70% with the recent biosimilars coming into the market. So that has increased to 70. Otherwise, it would be roughly around 50%.
Oh, that's a big number, and that's a big uptake of the biosimilar. Bharat sir, in your practice, what is the percentage getting dual antibody?
40%, 30 to 40% at the best. Because it was less than 10 probably with the original one. Now another 20, 30, 1/4 more are able to take now with the reduced prices of 1/4 of the original.
Fair enough. So let me go to the third panelist. Dr. Biswas, in your practice, would you choose a chemo-free regimen for any patient with HER2 positive metastatic breast cancer?
So there are certain occasions I have done that. So especially somebody who is not keen for, because we are discussing a metastatic, especially somebody who is triple positive. So I have done that. So where we have used both the antibodies and one of the aromatase inhibitors. And these are patients who are absolutely not want to get their hair loss or the toxicities of the chemotherapy, who are afraid of. These are situations we have used that.
So this trial was presented in San Antonio last December. And you can see that this ASPIRE trial was a multi-center, but it was a phase 1, phase 2 trial where they combined a CDK4 inhibitor with anastrozole and dual anti-HER2 therapy. You can see that the progression-free survival was around 21 months, but you can see the overall survival is roughly around 88% at 4 years. Dr. Senthil, what is your take on this?
I think it's a very interesting approach, Krishna. It's just that we need to choose our patients properly. I'm sure that as we move forward, we will use these gene signatures and Prosigna and things like that, which will help us, pick and choose these patients who will be appropriate for this kind of an intervention. But we still continue to use chemo plus dual anti-HER2 therapy in the majority of patients.
Fair enough. So I think the standard of care still remains chemotherapy with the dual antibody. But in patients who may not be fit, who are not willing, this is some backup for us to say that we can think about using hormonal therapy along with probably a CDK4 inhibitor as well. So, Dr. Bharat, in your practice, do you really stop anti-HER2 therapy other than, say, for toxicity in patients who are on this therapy for metastatic breast cancer?
In one word, no, never. Unless
I think
what you said, toxicity, not affordable,
Yeah.
you need some sort of a HER2 inhibition for the entire
Fair enough.
metastatic.
Absolutely. So in the present day and age, probably you would not stop it, but people are thinking of stopping it, and the Stop Her trial is on flow. Would you escalate in the maintenance? Say, for example, somebody with HER2 positive, ERPR positive disease, you have given chemotherapy 6 cycles plus anti-HER2. Would you escalate anything rather than continuing anti-HER2 therapy with, say, aromatase inhibitor, Dr. Biswas?
Yeah, so we commonly do that. So somebody who has finished chemotherapy, the disease is well contained. So definitely I will add one of the aromatase inhibitors.
So apart from the aromatase inhibitors, there are no solid data to back use of CDK4 inhibitors in the present day and age post chemotherapy, nor are there enough studies now, but the studies are going on to add tucatinib in the maintenance. So then came the next Olympian. So at the present day and age, probably TDM1 is our go-to drug in the second line. Compared to capecitabine plus lapatinib. Dr. Senthil, is this your go-to drug even now, or was it only till 2022?
It depends upon whether your patient has a deep pocket or not, Krishna. If somebody can afford Enhertu, I think in this situation that would be the go-to drug. But most patients, 95% or 97%, will not be able to afford Enhertu. So it ends up being TDM1.
So I think still in most of our patients, we would give TDM1. But there are some other interesting choices as well. There is a drug called tucatinib. So tucatinib started with this HER2 CLIMB study, where patients who had already received trastuzumab, pertuzumab, and TDM1 were randomized between placebo plus trastuzumab capecitabine versus addition of tucatinib. Look carefully, this study took up patients with untreated brain mets in addition to previously treated brain mets. So you can see that tucatinib significantly improved the progression-free survival and overall survival. And very importantly, in patients with active brain metastasis, it had a significant role to play. So even the updated overall survival shows a very impressive benefit. So in the present day and age, Dr. Bharat, have you used tucatinib, and what is your experience been?
Unfortunately, no. But the thing is, where I should use it when the main bulk of disease is cranial, active cranial events, and probably the extracranial disease is probably less of an importance. So probably in that case, I may think of giving tucatinib earlier than TDXD. Otherwise, I think so TDXD also have a good data now for CNS. but probably for a patient where CNS symptoms are predominant than extracranial, I may think of giving it earlier than TDX.
So, Senthil, any experience with this drug, tucatinib?
I just had 2 patients, Krishna, who have been on tucatinib. It's not an easy drug to tolerate. Both those patients ended up coming down to 50% of the dose, but they're taking it. It's kind of holding it on. But yes, that's the limited, vast experience that I have with tucatinib of 2 patients.
Absolutely. Biswas, any thoughts on this?
Yeah, I had experience of one patient, but that was post brain surgery and also proton, but significant toxicity, as Dr. Senthil rightly said. So we have to go down with the toxicity, means the dosing, and subsequently the patient GC went down. So we had to put the patient on bevacizumab for control of brain edema, and subsequently this patient is doing good on TDXD now for 11 doses. So definitely not a good choice.
Not an easy drug.
Yeah, absolutely.
Not an easy drug. So this HER2 CLIMB-2 study was one of the most important studies presented recently. It basically, took up patients who had progressed on trastuzumab plus taxane and subdivided them or randomized them to placebo plus T-DM1 versus tucatinib. You can see that the progression-free survival improved from 7.4 to 9.4 months with good benefit in the brain. Again, suggesting that tucatinib has got good intracranial presentation or intracranial activity. Senthil alluded to the toxicity as Dr. Biswas. And I think, Senthil, if you can just tell us in a few words, what are the toxicities which you faced?
So fatigue is quite a bit, mouth sores, skin rashes occasionally. These are the ones that these 2 patients with tucatinib have had. Some elevation in SGPT, SGOT is also something that we have seen. So that's what we've seen with in those 2 patients with tucatinib needing dose reduction.
So, Bharat, where would you place tucatinib? Would you use the HER2 CLIMB or would you use the second CLIMB now?
Sir, after third line, probably category 1 post TDXD.
So basically, you would think about the HER2 CLIMB study rather than the HER2 CLIMB-2, where you would probably use with the capecitabine and trastuzumab along with tucatinib.
Yes.
Fair enough. So then comes our main hero.
Krishna, can I just ask from the panel and you can push it?
Yes.
If you have an active brain disease untreated, who's not that symptomatic, would the panel go for a deruxtecan or a tucatinib?
Yeah. Dr. Bharat, can you take it?
Sir, provided extracranial is not much important, I think I'll give tucatinib earlier than TDXD. Maybe, again, this is the purity of the data I'm taking. Both have the data now with the analysis of Destiny 1, 2, 3. There were around 180 patients which had CNS meds. Definitely a good response rate, close to 40, 45. Impressive progression-free survival. In fact, in untreated, it was close to 17, 18. But again, it is retrospective analysis. What scores tucatinib over is it was a prospective pure data in a phase 3 setting, and others were basically a retrospective analysis. Again, telling both can be used, but probably where the cranial load is probably the cranial symptoms are more active, this I would prefer tucatinib over TDX.
Yeah, fair enough. So I think finally coming to the most important probably change in the last few years is the development of TDXT. And so Biswas, what do you think? What differentiates TDXT from TDM1? Why is it so much better? Is it the 100 grams better or what is it?
So one is efficacy-wise, and second, CNS activity. Third, even with toxicity, I think so TDXD scores over a TDM1. So if you choose drug by drug.
Okay, Senthil, do you agree with that toxicity and the other things?
I think toxicity, we should learn to manage the toxicity of TDXT, Krishna. TDM1, we found thrombocytopenia, liver dysfunction. We kind of now know how to go about managing it. We watch for it. So I think we will also have a learning curve with TDXT and ultimately learn to manage the myelosuppression or the lung-related side effects. So I think it's a question of learning it over time.
Yeah. So
But
I
it's
think
certainly a superior drug. It's certainly a superior drug without any doubt.
fair enough.
Far.
Probably because one of them is the payload is much higher. The drug which it is carrying is also a much better drug, and probably because of significant bystander effect. So if you look at the ESMO this year, there was a updated overall survival analysis of the randomized phase 3 DESTINY study. So what this study was is trastuzumab deruxtecan versus treatment of physician choice in patients previously treated with the TDM1. Why I brought this up is, in many of our practices, most of our patients would have received TDM1 in the second line setting. And this is where probably, we are thinking that post TDM1, what would trastuzumab deruxtecan do? Biswas, your take on this study?
So it is just a availability of the drugs now. So TDXT has now overscored TDM1, so that's why it is almost becoming a second line. It almost going up the ladder. So it is just the availability of the drug, and as Dr. Senthil rightly said, and handling the toxicity.
Yeah. Biswas, what is your take on this study? Because many of our patients would have been on TDM1. Does this study make us comfortable of using ADC post, another drug?
I don't know.
Sorry, using this drug, using one, TDXT post TDM1. Does this study make it reasonable for you?
Yeah. So make it somewhat reasonable to me.
Senthil, your take on this? Will this be useful in your clinical practice?
Absolutely, without any doubt. Because if you have TDM1, TDXT certainly works after TDM1. If I'm not mistaken, the response rate, as you're showing here, for the TDM1 cohort is actually around 50%. So it does work post TDM1.
Yeah, so I think this is a pretty important study, considering that many of our patients would have received TDM1 and are now progressing on it. So you can see that the progression-free survival significantly improved, and the response rate is also quite good. Also, there is data to suggest that in this study, the overall survival also is significantly better. So I think you have answered this. Bharat, your take on this implication of this DESTINY, you said you would use this drug.
Yeah.
But you would
TDM.
always prefer to use, instead of TDM1, using the DESTINY Breast 03. Can you just throw light on this study?
So probably a study which was probably a direct head-on comparison between the two in those who had taken trastuzumab in the first line. So a second or a third line, but trastuzumab. Now, when you look into the overall result, the PFS, it was 4 times better. I think probably it was for the first time when you had a standard of care and a new drug comes and the PFS improves from 7.2 to 28 months. So that marked probably what we need not have to discuss. So big difference, a very impressive hazard ratio. Even we have a OS advantage now with the final 53 versus 43. So probably, as said previously, this is probably a better drug than TDM1. So whenever the patient can afford it, I probably will try to use it earlier to maximize the quantum of benefit, I can say. Or to maximize survival, in other words.
Fair enough. This was the updated analysis published this year. Your take is also the same, or you have any difference?
No. It's absolutely fine. So at this moment, if somebody doesn't have a lung disease or lung symptoms or a ILD, and somebody has a deep pocket, so definitely, so this is the drug to go.
So I think we want to implement this study as soon as possible in clinical practice. But in every sport and every treatment, if we don't know exactly how to throw it and how to use it, you may cause injury. Senthil, is the injury serious like how this guy says, or is the toxicity of this overhyped, or is it rare for real? What has your experience been? Or what is your thoughts?
So I don't have so many patients to quote my experience, Krishna. I have a handful of patients. Touch wood, so far beginner's luck, I haven't had ILD, but my patients have not crossed to the point where ILD starts becoming a problem. So that's one important thing. So we should know when ILD is likely to happen, and keep our eyes and ears open, talking to the patient and doing those CT scans, surveillance CT scans as appropriate. It is a real problem. There is no way that you can say that it's not a problem at all. But it's important to make sure that we spot it early based on either your history or based on the surveillance scans that we will do and take the appropriate action. Then you are unlikely to burn yourself or end up like the footballer or the pole vaulter.
So is this what you are suggesting?
Yes, yes, the 5S,
5S
that's
rules?
correct. Yes.
So you would screen patients, and how often are you really screening them?
So I would usually do it once every 2 to 3 months, Krishna, though in the studies, some studies have actually used 6 weeks, if I'm not mistaken.
Yes.
Correct me if I'm wrong, but I think that's a little too frequent. We cannot do that in our patients. So 2 to 3 months is a reasonable period. The other thing is, since we're going to anyway do a PET scan, every 3-6 months, so it will not be very difficult for us to follow this protocol, because all the time you will also be seeing the lungs in the PET CT that you're doing. So from that standpoint, it is a little difficult, but it's not something that we cannot overcome at all. So it's doable.
Fair enough. Bharat, what's your experience been? And do you follow
actually,
this?
I had a bad experience. I'm on the other side. I had two
Okay.
patients with ILD, sir. So one patient, luckily, what we need to understand is ILD doesn't start. What sir said is it doesn't start on day one. It starts maybe after 4 to 6 months. When you look into the data, they say 267 days. So probably it is after the first 6 months you get these things. What is important? What is a new onset cough? Some starts thinking. So the patient basically you have to examine, or you have to be careful always whenever this patient comes to you, because I had two patients who took more than 1 year. One patient developed ILD, but again the thing was with steroid, it was one. So it was probably more of radiological and some of a cough related symptom, which went away with steroids, and we recontinued it for another 3-4 months. So most important, yes, radiological is important, but the patient starts having these symptoms of cough, some breathlessness. So you have to be careful about any symptoms related to lung when the patient is on this. And
Fair
probably
enough.
periodic, what you say, when you do a thing, you see these changes. You pick up these changes.
Dr. Biswas, your take on this?
So I have two patients. So one who has completed 11 months, 11 doses. Other patient who has 5 doses now. So the 11 dose patient is absolutely doing fine. And the second patient, I don't know. So is it because of seasonal change, rains? No. So she has some cough. So I've just put her on some antihistaminics. It doesn't subside. So she has just completed 5th dose. She's due for 6th dose. So
And when have you done the surveillance scans?
the surveillance scans were done 1.5 months back. So after 3 doses of therapy. So
Fair
she
enough.
good control of
So did you find that, because in this analysis which was done in the Destiny breast trials, they found out that if somebody had a renal impairment, they had a little higher chance of developing ILD. Did any of your patients have a mild renal impairment by any chance?
But both of them have some amount of lung disease as per cancer infiltrating into the lung mets. So one of them already had also sort of limited surgery also. So otherwise they don't have renal impairment.
So Senthil, what is your take on re-challenge? How do you really decide on re-challenge if somebody has had maybe a mild ILD?
I think it's okay to re-challenge. Maybe I don't know the guideline exactly, Krishna, but I think there is a place for re-challenge, especially if you just had a mild ILD and you recovered completely, because it's a very important drug and we don't want to throw it off just because there was a mild toxicity. Maybe we need to do scans at a much lower frequency if you're going to re-challenge this patient. But I wouldn't, desist from re-challenging, especially if the toxicity was very mild and the patient was all right with steroids or whatever intervention that was necessary.
Fair enough. So to summarize this, ILD associated with this drug generally occurs little later than what we suspect. We should be screening these patients, frequently scanning them. and listening to them and suspend treatment as soon as we hear or see anything. And the mainstay of treatment is steroids, and probably involving our pulmonologists who know something about it would be useful. So this is a few slides on patients with active brain mets. So there have been some studies of TDXT with active brain mets. I think Bharat alluded to this. There was a pooled analysis of TDXT in patients with brain mets from the Destiny 1, 2, 3 studies, which was discussed in ESMO 2023. You can see quite a significant number of patients with brain metastasis, around 148. And you can see that TDXT has some a significant benefit in these patients, whether they are treated or untreated. Bharat, can you just expand on this? What is your thoughts? Bharat, are you there?
We just lost him.
Actually, boy, it got disconnected. Can you repeat it, sir?
Yeah, regarding
Yeah, can you repeat the question, Krishna?
Yeah, I think you did allude to this data of TDXT in brain metastasis. This is the pooled analysis of this Destiny Breast 1, 2, 3, where quite significant number of patients with brain metastasis, and you can see that there is quite a good response rate, and the PFS is also quite interesting in both patients with the treated as well as untreated and active brain mets. But I know you made a very good point about this, in Sahu asked his question. Can you just go through this data of TDXT in brain mets? I think we lost him again. Dr. Biswas, your take on this?
So definitely this drug is in a untreated patients. So where you probably want to avoid radiation, that you expect this patient to survive beyond 6 months or a year. So definitely, so these drugs becomes a good choice.
Okay, Senthil, your thoughts on this data of TDXT in brain metastasis?
I'm quite impressed, Krishna. So I'm very tempted to say that even if somebody had active brain metastasis, I would use TDXT. I would probably sometimes do a little bit of radiation to the brain, some SRS, and then do TDXT rather than doing tucatinib, because again, there's 2 patients with tucatinib. I'm not a great fan of tucatinib because it's not an easy drug to use. So with this data that is impressive, I think it's quite all right to use this as an alternative. So that's my take.
Sir, I had a good experience. One patient had carcinomatous meningitis due to CA breast, and the disease completely went away with TDXT. So we had a 1 year for that patient. So it started with the 6th line with a carcinomatous meningitis. And probably the disease completely disappeared with TDXT.
Yeah, there is this phase 2 data, the DEBRA data, which showed that it's a very small cohort, I think 7 patients.
Bharat, your patient was without brain RT? Without
yes, sir, no cranial lesion, only CSF positive.
Okay.
Altered sensorium, CSF positive.
So you did not give any intrathecal also, it's pure.
No, we did not give intrathecal. TDXT we gave, second dose she improved. And he was fully normal for the next 6 months, sir. Then unfortunately, due to, it was when this drug was not in India, we got it from abroad, sir. But due to financial, we stopped. Again, she developed this and then she died, sir.
So this is the DEBRA data. There are very few data sets in patients with leptomeningeal disease. Quite a few with brain metastasis, but very few with leptomeningeal disease. And in this small cohort, I think of 7 patients, wherein the positive CSF cytology patients were taken up, you can see that patients had significant benefit with a median overall survival of more than 1 year. So, Dr. Sahu, I think this is, I mean, one of the good drugs, which is some data at least to suggest use in patients with leptomeningeal disease. Dr. Biswas, your thoughts on this? And at present, if you have somebody with HER2 positive leptomeningeal disease, what do you do?
So I use with intrathecal. So we continue with systemic therapy and intrathecal. So very rarely craniosspinal the palliative intent. And many a times, so either intrathecal methotrexate or like in leukemias we do triple IT also we have tried. So 3 months, 5 months. So we have done also in lung cancers with the leptomeningeal metastasis. Not tried intrathecal trastuzumab, though there are people who have tried intrathecal trastuzumab also.
Fair enough. Dr. Senthil, what do you do in your present practice for patients with leptomeningeal disease? And what is your take on this cohort?
So if my patient can get TDXT, then I would use that. But in reality, most patients would not be able to get that. So lapatinib capecitabine would be my choice for somebody with meningeal metastasis. If I have used lapatinib capecitabine and in spite of that, there is no response, then there have been a couple of instances where we have used intrathecal trastuzumab. Again, from Tata Hospital data, they have published a handful of patients where they have used trastuzumab. But again, in those 2 patients, I didn't find any impressive outcomes, but I wouldn't stop trying to do that. And then finally, change your systemic therapy. There's always a rare chemotherapy that gets into the brain and then it might help. So that's the sequence in which I would do if I don't have TDXD and tucatinib.
Fair enough. So finally, will Javelin become our go-to, first most famous or most important sport? This is the Destiny Breast 07 study where they tried to use TDXT versus TDXT pertuzumab in first line. This was presented in ASCO this year. Bharat, your take on this study?
Very impressive data, small numbers, 1B2. So probably we will wait for 9, which is a phase 3. But yes, probably in future, you might have this drug as a first line. Because if you look into, I'll not go, because if you see the PFS in the second line, 28 months, which is better than the Cleopatra of 18 months. So probably, yes, everybody will agree that this drug might replace the other drugs at the first line, because even in second line, its PFS is better than the first line. Maybe, but we'll have to wait till now. Probably a best drug in the second line. But yes, future is, I think this might be the first line drug. And let us see, sir, at present.
Fair enough. Dr. Biswas, your impression on this?
Definitely promising, but we have to watch out for, since we are moving up the ladder, so definitely toxicity will be a concern. So we have to look for those things.
Yeah. Senthil, are you worried that this drug may come in the first line? And if ILD is an issue, somebody who's anyway going to live for quite a long time, you're introducing ILD early. Are you worried about that?
That will be a challenge, Krishna, without any doubt. Managing toxicities and managing the cost, more importantly, over time, unless you get 10 cycles and then you get the rest of it free, something like that comes up, it's going to be very challenging to use such expensive combinations. But that should not be a deterrent to progress. We should get these, and then we'll find some way of getting it for our patients as time goes by, hopefully so.
Yeah, so I think I will end here with all the 3 panelists' final comments on how to manage HER2-positive metastatic breast cancer as on today. Would this guidelines, really bring out your thought process? Bharat, is this what you think nowadays in your present practice?
Perfect, sir. I agree with whatever has been written. The times are exciting. From a drug, single drug called trastuzumab, maybe, sir, when I started my career, so many new choices over a period of time. So good, yes, sir. But I agree with the algorithm that you have given, and I think most of us follow with the same way, I think.
Fair enough. Biswas, your final thoughts on HER2-positive MBC?
So there will be certain patients who will behave like a oligoprogressin, like EGFR or ALK. So you should not forget local therapies. Somebody who is hormone positive, so bring AIs into picture. So probably you are going to improve the survival. So you can play your drugs well.
Senthil, your final thoughts?
I think from an evidence-based standpoint, what you're seeing on your screen is the right thing to do. But the reality can be very different. You may want to use TDXT in some patients because we're impressed with that. We've got better access to it. So drugs kind of move this way and that way, depending upon many other factors, not just based on scientific evidence. But in principle, this looks fine.
Fair enough. So I think with that, I would end and hand it over to Dr. Sahu.
Yeah, I think there are 2-3
questions
that your panel can answer, Senthil or anyone. First thing is Amish has spoken about, which we discussed yesterday, Dr. Senthil. After TDXD has been done, what is your further line of action?
Tucatinib, trastuzumab, if you can get tucatinib, trastuzumab, That would be one thing to do. We just don't have data for anything post TDXT, but whatever you can lay your hands on, you need to try it one after the other, because you are not going to get, 500 patients.
So you are not happy with using TDM1 after TDXT?
We just don't have any data. At least intuitively, it is less likely to work. Not that I'm saying it will not work at all. There might be differences in mechanism of resistance. We again discussed this yesterday, Sabu. That is where this nuclear medicine-based HER2 scans may come into being, because it seems to be that if there is heterogeneous expression of HER2 receptor, TDM1 seems to be a bad drug there because of the pharmacokinetics, its linker, its payload, the way it is chemically also. So I think as we move forward, we will have some factors based on which we can make these decisions, not just saying all comers based on scientific evidence, and the randomized control trials should go from one to the other. So hopefully in the future, we'll get some tests to use these drugs on our patients, some predictive value.
Dr. Amish, you wanted to ask anything more?
Yeah, actually, the even NCCN guidelines also have said, and Dr. Krishna also put in his algorithm, this is not correct. In the third line, even guidelines say that you can use TDM1. And I agree with Senthil that just because TDM1 is better than the TDXD is better than TDM1, you can't put one down. It is like in the lung cancer, in ALK positive, you have 4 category 1 recommendation. You don't put that one is inferior. That's why that's after lorlatinib, you will give crizotinib.
So they will say preferred, Amish. If 4 category 1s are there, they will say of the 4 category 1, there will be so it's first among equals. So
yeah, my point is, we are forgetting Emilia trial also, the evolution of TDM1, TDXD, but in that Emilia trial, if you see, lapatinib also worked quite well. So I was thinking that lapatinib plus trastuzumab re-challenge would be a better option, and I have few patients who have done very well after TDM1. I don't have enough experience.
We all do. I have enough patients also, Amish. So do we have a choice? So that's the way I look at it. You can't send these patients home because there is no data of CAP-LAP after TDM1. We will use it without any doubt.
No, so in our algorithm, I think we have to not forget LAP-CAP or LAP plus trastuzumab re-challenge. That is what
the other thing we should not forget is also abemaciclib plus trastuzumab plus fulvestrant.
That is a wonderful.
That's something that you always forget.
Correct.
So that's another important.
So many.
Okay, so I think if there is anything else to be done, Dr. Amish can take it in his panel on TNBC and add 2 minutes of HER2 positive disease also in that. So I think we have saved the best for the last, and we have Dr. Amish who will be moderating the last discussion of these 2 days deep dive into breast cancer treatment, and he'll be speaking on the advanced TNBC, and we have his panelists. We have Chirag sir, we have Dr. Bharat who will be continuing with it, and apart from these two, we will have Dr. Soumya. Soumya is there? Can someone confirm if Soumya is there?
Yeah, Dr. Soumya is there, sir.
Soumya is there. So Dr. Amish, you have a full house. So next 40 minutes is totally yours, and then we'll have the expert opinions of the day 2 from Dr. Shyam Agarwal.
Thank you so much, Tarini. My slide is visible.
Yeah, before that, can you take one, because people have been talking re-challenge. After you have a great toxicity of a ILD in TDXD, would you be re-challenging? Would you be brave enough to re-challenge?
No. It is asymptomatic ILD is the only place where so far in the
grade
guidelines.
1 and 2 max.
Only one, sir.
Only one asymptomatic ILD, Tarini, very crystal clear guidelines. Very crystal clear guidelines.
2 also is
no.
Yes,
Symptomatic ILD, the moment patient experiences, as of today, you are not supposed to re-challenge with trastuzumab deruxtecan. Period.
I think that is one message that should go in very, very clearly.
Yeah. Okay, perfect. Thank you, Dr. Chirag Desai, Dr. Bharat, and Dr. Soumya. Next 40 minutes, let's see if we can tolerate each other. I think I wanted to start with these guidelines, NCCN guidelines. It's a triple negative breast cancer, advanced disease, systemic therapy regimens for stage 4 M1 disease. And The first line treatment is something which we all practice and we all follow. But my first question to Dr. Chirag Desai, because we have discussed this earlier also, that if you have PD-L1 more than 10, and if you have a germline BRCA, what would you prefer first, olaparib or pembro plus chemo? In a treatment naive patients, they have written here irrespective of germline BRCA, because the NCCN follows the trials. But if you see Olympia trial, the treatment naive patients, they did quite well. In fact, the PFS and OS, if I'm not mistaken, went beyond 2 years.
So in this situation, the only data we have with immunotherapy is in the first line only. While in Olympia as well as in the Telozopari trial, we had the patient in first, second, and subsequent line treatment as well as the best outcome was in the first line. But I will still want to go ahead with immunotherapy and chemotherapy in the first line, followed by olaparib on progression.
Okay, so you would like to give chemotherapy and then make olaparib redundant just for 4 months rather than use it for 16 months. Chirag bhai, I'm not arguing. I'm just asking a question.
Sir, with also we should never do a cross trial also. So olaparib 6 months is PFS, 19 months is OS. When you talk about Keynote 522, it is 9.2 plus 23. So at the end of the day, that quantum of benefit is again better when you use IO and chemo in the first line. Maybe again, we should never do a cross trial comparison.
We do not, to the best of my knowledge, Bharat, we do not have a subset of BRCA positive in Keynote trial. Let's not forget that.
Yeah, but at the end of the day, that benefit is better there.
Yeah, I think for the tail of the survival, we are looking at CPS more than 10. We don't want to miss the window of opportunity. Dr. Soumya, what would you do?
Yeah,
Dr. Soumya?
So PD-L1, if more than CPS is more than or 10, then probably I'll go with immunotherapy plus means pembrolizumab plus chemotherapy, even if the BRCA is positive, just because the patients who respond well, they continue on responding well. And we don't have a direct data to tell that which one is better, definitely. But
Right.
what I do is that I do a pembrolizumab plus chemotherapy.
Right. So here, again, like TDXD and TDM1, I am in little disagreement with NCCN guidelines, because, they said regardless of germline BRCA, this is some line which I have my issues with. Chirag bhai.
Yes, so one more point in favor of using immunotherapy first is that there is always a tail end, which is flat in immunotherapy, which is never there with anything else.
Right. And we all have, see, we don't have the data that after olaparib, if you use immunotherapy plus chemotherapy, you won't see the tail.
Yeah.
Right. So that's why I said that regardless of germline BRCA is something which I feel is, something overstatement here. Let's move on to second line. Second line is, today we are going to discuss about this. I just put the 2 arrow here because we have sacituzumab govitecan as the category 1 preferred, and we have a trastuzumab deruxtecan category 1 preferred. Okay, so both are category 1 preferred, and we will see how do we go forward. So let me start with Bharat. Bharat, you do BRCA 1, 2 germline somatic in all your patients with triple negative breast cancer?
Yes, sir. Yes.
Okay. Dr. Soumya, when do you do NGS in metastatic triple negative breast cancer?
What I do is that mostly in the later lines. So initially I do a PD-L1, I do a BRCA, germline BRCA, and then take a decision. In later lines, I do a NGS.
So PD-L1 report comes in 2 to 3 days, Soumya. If you have PD-L1 more than 10, would you go for germline BRCA? Because Bharat said he will do it in all comers. But Bharat is not going to use olaparib or PARP inhibitor in the first line if the PD-L1 CPS is more than 10. Why waste resources, Bharat?
Still, I'll do that. I'll complete that. Because in later lines, anyway, I have to do that.
Anyway, you have to do it. So you will do everything. Germline BRCA is not running away. and it is going to be there irrespective whichever line you use it. Okay, point well taken. Chirag bhai, you do NGS. When do you do NGS in your patients?
So before that, I will not do somatic BRCA in my patients. I will do only germline because we don't have any data for somatic. That is the first thing.
And we have data now.
It's not so very convincing, not phase 3 data.
National Breast Cancer Research Consortium, this ESCO also, there is a nice presentation, 50% response. Better PAL B2.
I feel Chirag bhai, Bharat is right that we have now enough data in breast, ovary and others that somatic BRCA behaves almost equally like germline.
Yes.
So I
Yeah,
think,
we
if we are doing NGS anyway, we will get that BRCA.
Right. But the way I have learned this is, pelvic organs, ovary and prostate do somatic, and extra pelvic, that is pancreas and breast, do germline. That's how I have.
Sir, Abhi data has come now in this
Right,
also.
right. So Chirag bhai, when do you do NGS?
Yes. So NGS I will reserve for the later line because sometimes some mutations may develop under pressure with the first line, second line chemotherapy. So that's where I will be using the NGS.
Okay, perfect. So, this was the background on which I wanted to start my case. So this is the 38-year-old female. She was diagnosed as triple negative breast cancer, CT2N1M1. There was only one met in the spine, and this was not biopsied. It was just that it was one met in the spine. Patient was treated in TMH. She was treated with a curative intent of neoadjuvant chemo, followed by surgery, followed by RT to breast, and they gave radiation to spine also. 14 months later, patient developed recurrence in the liver and bones. In the bones, there was a pelvic, shoulder bone, and spine. NGS was done with BRCA1, 2. There was no germline BRCA1, BRCA2, but patient had PIK3CA positive. Okay, this liquid biopsy was done. I'm very fond of liquid biopsy nowadays, but this was earlier days, and I got the liquid biopsy because patient was little reluctant to do the tissue biopsy, and we found PIK3CA. So this particular patient, if you see, is 14 months later, patient relapsed and now has metastasis in the liver and bones with PIK3CA positive. So let me start with Soumya. Soumya, how would you treat this patient?
Sir, this patient has already received chemotherapy and now PIK3CA is positive.
Correct.
So I look at the PD-L1 and then take a decision regarding if not exposed to carboplatin, probably gemcarbo and pembrolizumab. If the PD-L1 CPS is more than 10. So I'll right now I'll not give much importance to PIK3CA because the CAPItello data is not that encouraging. So probably I'll go to.
So you are now going for CAPItello data. Before that, good, you said that. We'll come to that, Bharat.
Sir, I will treat it like a normal de novo metastatic more than 1 year after completion of adjuvant. So a chemo plus a IO, provided the CPS is more than 10, I'll go ahead with the first line like that. PIK3 will not change.
So Bharat, help me understand here. This particular patient had PAT-CR during surgery, and that's why capecitabine was not given. But going by the fact that patient had one met in spine, would you have given adjuvant capecitabine to this patient?
Yes, sir. If this would have been a PAT-CR, probably no, because sir, that we don't have a data as far as CreateX also. Maybe that one bone might be a.
Assuming the biopsy was positive in that one spine met, would you have given capecitabine because we have radiated spine?
Sir, if the patient would have achieved a pathological CR, probably we would have to understand that was in spine also. So no added advantage of giving a capecitabine. Provided if she would have not achieved PAT-CR, I would have given a 6-month capecitabine because we are going ahead with a curative intent. So probably yes, create. But when there is a pathological CR, I don't know, or probably there is no added advantage of giving a capecitabine because there also there would have
Chirag bhai, my question is that oligomet we have, and we have in the breast there is a PAT-CR. This patient was not given adjuvant capecitabine, but I'm asking in your practice, going by oligomet and extrapolating data, would you have offered adjuvant capecitabine to this patient?
Not really. I will agree with Bharat that if the patient had PAT-CR, in breast, I will assume that patient has PET-CR in the bone as well, because since it is radiated as well, in addition to chemotherapy. And I will not be using adjuvant capecitabine.
You would not be using adjuvant
I
capecitabine.
will not have to create X. If you look at SYS UCC data, extended adjuvant low-dose capecitabine for 1 year, then it may be a case, but that is for adjuvant, not for neoadjuvant and PET-CR.
Okay, perfect. My point was that, this because it is a oligomet, that's why. But I think, and I agree with panelists. So, Dr. Chirag Desai, what would you do with this PIK3CA, which has come up now in the first line metastatic disease?
So nothing at the moment. We don't have very good capital data. So I will be using carboplatin and paclitaxel, since it is 14 months since previous chemotherapy. And if PD-L1 positive, add immunotherapy.
Add immunotherapy, otherwise chemotherapy. Okay, perfect. So, we are going to talk about capivasertib, and I just wanted to say that in breast cancer triple negative, in HR positive, in prostate cancer, in hormone sensitive and refractory, capivasertib trials are going on. And in November of 2023, US FDA has approved capivasertib plus fulvestrant for HR positive, HER2 negative breast cancer. Okay. And let's see now in triple negative breast cancer, this is a PACT trial, which is a phase 2 trial. And it's a first line therapy for metastatic triple negative breast cancer. I just want to highlight that there was 140 patients were randomly assigned in 1:1 to capivasertib plus paclitaxel versus placebo arm. And they did the mutation analysis, and this was basically the patient data. Side effect profile were definitely higher with capivasertib, but it was not that it was not manageable. Now, I wanted to highlight here that in patients who had, now this is A, B, and C. If you concentrate on the B, patient who had any one of the mutation, either PIK3CA, AKT1, or PTEN, this was the B group. You see the hazard ratio is 0.30 compared to paclitaxel alone. And you have a median PFS of close to 10 months as compared to 4 months with paclitaxel alone. And this is a phase 2 randomized data. And it is from the good group of phase 2 randomized data. Peter Smith is there, the same guy who gave us neoadjuvant immunotherapy. So if we didn't have the phase 3 data, I will start with Dr. Soumya. Dr. Soumya, based on this, I would be really tempted to give capivasertib.
I agree. The P10 population, especially if you look the 9 months versus 3 months, that is just the graphs are very wide, and the phase 2 data really looked good. So it is always a bad news when it comes the capital 290 results. That was always a bad news, because we always thought from this trial that definitely it would give us an advantage. It was a little bit surprising. The phase 3 was unfortunately negative.
Right. Dr. Bharat, what do you say?
Sir, now we have a phase 3 trial. So probably if I
we are coming to phase 3 trial, but based on the two, and this is the overall survival, where it was not reached median overall survival in PACT trial versus 10.4 months with chemotherapy alone now. Okay.
Sir, impressive data, but again, it is a phase 2 small data. So probably will it determine our practice? Probably a difficult question to answer. But yes, sir, it was an impressive data. But unfortunately, with the phase 3 now negative, I think so probably we may not be inclined to use this drug now.
Dr. Chirag Bhai, what do you say?
So, I will give an example that long back we had a PARP inhibitor called Iniparib that was tried out in TNBC along with docetaxel. Very impressive data in phase 2 trial. But the same drug in phase 3 trial didn't show any advantage, and now nobody is talking of that drug. So that's the example. So the same thing happened in this drug as well.
Okay, perfect. Capivasertib is getting launched in India. I think they are targeting more of HER2 positive disease rather than triple negative. But Capitello trial, this is the what I was talking of November 2023, and European Commission also has approved. The drug is not bad. But why I have kept this slide blank, because I wanted all the three panelists to add on to something. Apart from press release and apart from news media, and it is 910 patient trial, phase 3 trial. Do we have any data on subset analysis? Do we have any data, or it is just the press release? Bharat?
Sir, after when you said I searched everything, no data. Sir, of AstraZeneca, that press release is there that it has failed in its primary endpoints of PFS, sir. But probably detailed data we need to get it, sir.
So
June
out of
18th,
910 patients, assuming if you have only 40 patients where AKT PIK3CA pathway was mutated, will it be a good data? Because nothing, we know nothing about it. Just based on press release, you would forego packed study data, Bharat?
Sir, unfortunately, yes. When the final endpoint of the trial is negative, in a phase 3 in a 910 patient, I think we need to consider it as something which has failed.
Which has
some
failed.
Of the things, some
Dr.
positivity
Soumya, for
should have
you
come.
also in triple negative, Capivasertib is dead right now?
Right now dead because the company itself has given us a press release. No data is there. So it was very surprising also, but that's how the things are.
Chirag Bhai?
Yeah, same. I mean, this trial had two co-primary endpoints. The all-comers as well as the P10 population, mutated population. And in press release, there is some data. It reads that the first-line treatment for advanced metastatic disease. No, I mean, we don't have any good data presented. So, yeah, we will want to look at the data, but whatever data has been sent in the press release is not looking so good. And in that case, we have to forget about that drug.
So we have to forget about that drug. I wanted to remind when we move forward from Capivasertib, because even in HR positive, it was in all comers, but FDA gave approval only and only if you have at least one PIK3CA, AKT or P10 alteration and by an FDA approved drug. So I think Capivasertib as of now in triple negative with PIK3CA, at least in first line or the second line, is not there. So coming back to our patient, as Chirag Bhai said, we gave Paclitaxel, patient responded well for 5 months, progressed on the 7th cycle. Second line capecitabine was given, patient progressed in 3 months. I explained about sacituzumab govitecan, and we did a repeat biopsy in liver this time, and it was ER/PR negative and HER2 1+ at 2 places. Now, my question is whether it is sacituzumab govitecan or whether it is trastuzumab deruxtecan. So before we go on to ask the question, I wanted to share this data because I know the answers. We have been talking about Enhertu since yesterday. So I wanted to talk about, this is the final results from the randomized phase 3 ASCENT clinical trial. Here, what they did was they did the TROP2 by IHC and HER2 by IHC. Okay. And I asked Dr. Jay Mehta, I called him today and I said, do you do TROP2 in India? He said, no, but I'm planning to get it because you are the 10th medical oncologist who's asking me this question. So very soon we will have TROP2 and we can easily have, it's an immunohistochemistry, all you need an antibody. And what they tried to do, and it is a patient population which is there. The median number of the chemotherapy which was given was 4 basically. And this was the overall. We all know that ASCENT is a positive trial and it has been approved by FDA in triple negative breast cancer. At least 1 line minimum patients should have received. This was something I wanted to highlight. This is a TROP2 score, 0 to 130, 130 to 220, 220 to 275, and 275 to 300. And if you see the overall survival in the 220 and above quartile, the hazard ratio is 0.344 to 0.358. And here in this quartile, you have median overall survival is double compared to the first two quartiles. So let me ask based on this data, and let me start with Chirag Bhai. Chirag Bhai, if the TROP2 data is available, if the TROP2 by IHC is available, and if you say score is 275, would you look at in this particular patient where HER2 is 1+, would you even think of trastuzumab deruxtecan, or would you go for sacituzumab govitecan?
So I will surely go with sacituzumab govitecan. But even without looking at TROP2 data also, if we look at the data of DESTINY-Breast04 trial, the primary endpoint was PFS in hormone receptor positive patients, not in the triple negative patients. And in triple negative patients, there were just 58 patients, 40 patients on Enhertu, and 18 patients on treatment of physician choice. So we don't have very good evidence of that drug working so well in triple negative patient. Until then, I will be using sacituzumab govitecan ahead of Enhertu.
Okay, Bharat?
No, sir, I will agree with what you said. And in fact, this is the best thing it came out from. This is now we can decide on because again, head-on comparison, when you do irrespective, even in this 47 patient, if you say HR negative, TDXD had around 8 months of PFS, which was better than 6 months, and OS of 17 to 18 months, again better than that. But they were different population. But I agree, sir, probably when this TROP2 is available in this quartile 3 and 4, I think we should have no doubt now. Sacituzumab, even with the impressive data of TDXD, we should use sacituzumab. But I think we should start doing it, sir, and whenever it is available, because that will give us a fairer idea about how much maybe this drug is good, but the quantum of benefit will be always good when your TROP2 by IHC is so good. So I think this is data in a final analysis has given us more finer points on deciding what to use drug in which situation.
Okay. And Bharat, if you go for Q1, the first quartile, if you have a TROP2 available, and you have a 45 and 35 patients, not a small number, and you see there is not much of a difference, the hazard ratio is 0.739, but that is because of the separation of curve in the median. But median OS, not much of a difference. If you have a TROP2 available, and if you see in the first quartile, say the score is 80, and patient says I can afford Enhertu also, and I can afford Trodelvy also, which one would you give?
Enhertu. I'll give Enhertu.
You will give Enhertu.
Yeah, bystander effect is very good. Absolutely no doubt.
Right. So what Chirag Bhai said, that irrespective of TROP2, the SG scores over TDXD. Bharat, you don't agree with that.
Okay.
Okay, Soumya, what do you think?
I'll be worried in the low TROP2. This paper actually is showing like it's if you look at the hazard ratio and the values, the quantum of benefit, it clearly shows that as the score increases, there is definitely the quantum of benefit also increases. So from this paper, though the authors themselves have written in discussion 2-3 times that it is unnecessary to do a TROP2, however, from the paper, it is very clear that the score is really important, and it will worry me if the patient is exposed to sacituzumab govitecan in a low TROP2 population. It will get me worried.
So Soumya, this is ITT. Okay, this graph what I am showing is ITT. Yeah. And going by Senthil's lecture, although I attended only last 10 minutes of that, but going by Senthil's lecture, this was ITT. This was where it was positive. But this ITT also reminds me of, yes, tech support. You wanted to say something? You have raised the hand.
No, sir.
Okay, perfect. So this reminds me of Keynote 048 in head and neck cancer. CPS more than 20, did it drive the ITT? CPS more than 1 to 19, did it drive the ITT? And in non-small cell lung cancer also goes. So Bharat, do you think that the B OS curve 11.8 versus 6.9 months was this driven by third and fourth quartile? That means that if the TROP2 is on the first quartile or negative side, you should not use SG. We have sufficient evidence to say that.
Sir, no, actually, you should use it irrespective of quartile. That is what.
You are changing now your stance.
I'm not changing. I'm
Bharat.
comparing between the two, sir. You cannot waste such a good drug, sir. The only thing is, but again, at the end of the day, sir, the thing is, the message that is there that you should use it irrespective of the quartile. But the quantum of benefit, I agree with what you said with the second, that it is probably driven by quartile 3 and 4.
Okay. Chirag bhai?
Yeah, so till the time we have personal experience or the experience from many colleagues in our country, I think I will take my decision based on the data available and not based on subset analysis of any of the trial.
Okay. I think half of the IO drug is approved on the subset analysis, Chirag bhai. You know, we cannot run away from that, although that may not be the driving factor, but how FDA decides and how they do, sometimes it is beyond my thought process. But like I wanted to give here DB04.
This is not such a wonderful difference between the two arms. So if
Yes.
you there,
No, so I wanted to say here that the median progression-free survival in the hormone receptor cohort was 8.5 months versus 2.9 months in the DB04. But if you see here, the median overall survival was 18.2 months versus 8.3 months. Okay. Now control is 8.3 months. And if you see here in all the subgroups, the control arm is almost similar. So Bharat, I agree with you that you do not do the cross-trial comparison, but the control arm in this and this seems to be doing equally well. Does that mean that Enhertu is better numerically compared to SG, even if it is a fourth quartile? Bharat, let me scratch your brains.
Yeah, probably yes, sir. That is what, in terms of, if you say cost trial, definitely looks better. And sir, we have experienced that drug. It is a wonderful drug, sir. So point where, but then again, difficult to compare. This is the most difficult question to answer now, sir. But then again, everybody has to make their own choices. Data is small, but very impressive. Ascent data is big, but again, with this new final analysis, it has made us to realize maybe, again, that is also a post-hoc analysis. Quartile 3-4 has driven. And again, what sentences say, whether you should take away the entire data or take this post-hoc analysis, difficult to answer, sir. Again, more confusion.
Soumya, if this particular patient says, sir, aap batao Enhertu do ya sacituzumab govitecan, 38, 39-year-old female. What would you give? Drop to data we don't have.
I'll give sacituzumab govitecan.
You'll give sacituzumab govitecan. Okay, perfect. And if you have a drop to data and it is a first quartile where the score is low, sacituzumab govitecan or TDXD?
So I'll give sacituzumab govitecan, but I'll tell it might not that. So I'll give sacituzumab govitecan till now.
Till now. Okay, perfect.
Numbers are still less.
Numbers are still less.
They have given a p-value interaction also for each of them.
So the richness of data is more with SG as compared to TDXD. Soumya, that's why you would go for that.
No.
Yeah. Amish, one more thing, that in Enhertu trial, in Destiny-04 trial, the patients were treated with 1 to 2 lines of chemotherapy in metastatic disease, while in Ascent trial, it was 2 or more lines of chemotherapy in metastatic disease.
Yes, what I wanted to basically highlight that the separation of the curve in the third and fourth quartile is so high, there is no way you can compare SG with Enhertu, and you should not. I personally think is that, and I have told Dr. Jay Mehta that please make TROP2 available, because our decision making would be better. You know, both the drugs are very, very expensive as of today. Like, you know, at Trodelvy, I must have said 20 patients, out of which only 1 patient, that also 3 doses, not more than that. Okay, so this particular patient took 3 cycles, responded well. After 4th cycle, stopped SG because of travel and reasons unknown. Most probably it was a financial toxicity. Came back to me after 6 months. PET CT liver studied with metastasis. Repeat biopsy, again the same, PD-L1 0%. Now, question is, what about enfortumab vedotin, EV? Let me ask Dr. Soumya, and this is our last abstract for today, and I have 3 more minutes left. Let's go on to the last abstract.
So the EV202 trial, that is the subset that is even patients who are govitecan.
No, would you give EV202 in this particular patient? Because if you see patient progressed on capecitabine, patient progressed on eribulin, patient did not respond well to first line chemotherapy also. So is the chemotherapy out in this particular patient? We still have PIK3CA. I did the repeat liquid biopsy. Would you add here any PIK3CA, say alpelisib or anything?
Oh, I won't add alpelisib in this setting.
So this particular patient, Soumya, NGS does not matter.
Yeah, and just doesn't matter
Yes.
because of the capital O data and then the PDL1.
Okay, so let me put it that way, that if you have PDL1 more than 10%, that means that you will give this particular patient IO plus chemo first line, SG second line, and probably EV third line, suppose assuming if it comes as the approval. Do we really require NGS in triple negative breast cancer in the era of ADCs? Soumya, yes or no?
No.
No. Bharat, yes or no?
Yes, we have further options available. NTRK, very rare. Rarely MSI also, maybe. So you no, basically we have given. Sir, I will still do it, sir.
You
When
will still
it is
do it.
available, it might give us some more options, maybe. When we are short of so many options, it might, some things comes out which is targetable. So why not give a chance when we have
Why
the
not
facility?
give a chance? So you will give a chance after 2 ADCs or you will give a chance upfront, Bharat?
One ADC definitely. Enfortumab is a very small data till now, but yes, exciting data, and it tells us that you can still give a ADC after ADC, maybe initial again. But
Right,
yes,
right.
yesterday there was a debate, Seki versus trastuzumab deruxtecan. Maybe both have the same topoisomerase inhibition. This is an entirely different drug. And I think so. The data will be more impressive, like what we have. Data of enfortumab best is with Pembro in like urothelial. So I'll be more excited to see this drug along with Pembro here in breast. Maybe that might give us the real value of this drug in TNBC.
So would you be doing TROP2, HER2 and Nectin-4 also in all the patients if it is available?
Nectin-4, I'm not sure because, sir, as per as the data, or most of them will have a very good staining
That is
for
in
that, and it did
urothelial.
not.
That is in urothelial. In breast, we don't know how many would be expressing TROP2, how
Yeah,
many
so-
HER2, how many Nectin. Bharat?
Too early to say for Nectin, sir, but remaining two, yes. Now I'll start because these drugs are very costly. You have re-emphasized one of the best thing I learned today. Something more from you. Probably we should start doing it because of the probably the value of that drug, the cost constraint we have. Enfortumab, actually, sir, I'm probably a bit excited, but not sure. Like we still have to wait for phase 2, phase 3. But first time we have some data to say that ADC after ADC, there are 19-20% response rate. So
Correct.
something to think, sir.
So, and 1/3 of the patients had SG earlier. Chirag bhai, OS of almost close to 1 year in the third line, fourth line. Isn't it very exciting?
That is exciting. And so, it is instead of having PFS of just 3.5 months. So that is something unusual, but the data is there. A very small number of patients, 42 patients. So we need to keep up looking at upcoming data of this trial as well as multiple trial. But this data is exciting.
So assuming in the phase 3 trial, Chirag bhai, I would again repeat this question because this I have at least seen 3-4 different lectures on this. So it is not the question which I have generated in my mind. The question is, if you have 3 or 4 targets in 3 different lines, and if you have ADCs of those targets, like TROP2, Nectin, or HER2, like we have, would you really require NGS in future? Because even today also, how many NGSs has really helped live patients beyond 1 year, 2 years?
So for most of the patient, NGS is out of desperation rather than any calculated testing. But as Bharat said that we want to look at something like NTRK in 1 out of maybe 500,000 patients. But everyone is doing it, so I also will do that.
Dr. Soumya, last comment from you and then over to Tarini.
So IO plus ADC is coming up in a big way in TNBC. That's what I feel. The combination of IO plus ADC will be there in future.
Okay, perfect. So our patient did not have money for EV. or any other line. So we gave vinorelbine, there was no response. We gave eribulin, there was no response. But performance status was 0 to 1. So right now they are arranging money for EV based on the data which just 3 days back I shared with the patient. And with this, thank you so much all the panelists, and over to Tarini. Thank you, Tarini.
Thank you. Sir, wonderful panel. Excellent.
The take home is 3 cycles of sacituzumab made the patient lose everything. So, so 2 cycles of EV he will then probably lose everything, rest of the things. So with that, thank you, Amish boss. I definitely, as always, you bring out those things which you wanted to discuss, and thank you all the panels. And now we have Dr. Shyam Agrawal, who's going to brief out the whole thing, what we did, the metastatic breast cancer, and what we can take home and how we can change practice for tomorrow. So, Dr. Shyam, sir.
So, thank you, Tarini, and congratulations to you and your entire faculty and panelists for really putting an excellent show with tremendous attendance, possibly, unprecedented. So you really deserve kudos from all of us on, organizing this webinar. Now, coming to, what we've been discussing today and even yesterday, it's been really engrossing and bringing out several salient new features which sometimes, are not discussed or not covered. I think today's discussions really started with metastatic HR positive metastatic, breast cancer, as to what should we be doing for patients who have failed CDK4/6 inhibitors. So I think we are, having choices today between, alpelisib, and now you have the AKT, capivasertib, we have oral SERDs. So, those kind of, drugs were discussed, and we did figure out that, alpelisib is certainly a drug which is very toxic and is driven because of the PIK3C. So you have the potential of new drugs coming in, such as capivasertib and oral SERDs. And then, of course, we did discuss the trial post-MONARCH, in which Abema was combined with fulvestrant, and you have the MAINTAIN study. So I think what we perhaps need to also understand, which I mentioned in the chat box, was the tempo of relapse and the sites where the disease is possibly relapsing. So, if you have a slow tempo and a patient is failing on CDK4/6 and AI, and, you can certainly consider, fulvestrant and continue with Abema, or change the CDK4/6 as was discussed. And I think in the last slide, which Dr. Amish showed, even in patients who are HR positive, HER2 negative, I think the data for enfortumab vedotin was quite promising. Even better than TNBC. The overall survival was touching almost 20 months in patients who had failed earlier. So you have several choices, and we're not talking about chemotherapy. We do have the option of TBXD for a patient who is HER2 low or ultra low. And so it's a sequential treatment which you have to adopt, and you have to, discuss at each step with the patient as to, depending upon, of course, the guidelines and what is available, and economy does become an issue, as you discussed and as you said, in particularly TNBC. So I think we are really having several choices after the failure of CDK4/6 and AI in HR positive NBC. I think then subsequent to that was the Senthal's classic, presentation on how to analyze the forest plots and heterogeneity, pre-specified groups. And of course, he took the help of 2 trials and several other trials, Sudeep Gupta's trial and the lung cancer trial. So I think perhaps you need to, dwell more into this, because as I'm seeing, because of a lot of DNB students coming in, major analysis are being done, on large number of patients. So we need to have pre-specified criteria, especially if you're doing prospective studies. But then the issue of post-hoc analysis was also covered. So I think Santhil's was a classic presentation. Then, of course, followed by the HER2 positive MBC. And again, as we all know, so many drugs and so many options have become available now. And the non-chemo options, whether you are combining it with the anti-HER2 drugs like trastuzumab, pertuzumab with hormone, and the latter part, we were discussing the use of TDXD with other HER2 partners like pertuzumab. So, maybe at some point in time, we are talking of non-chemotherapy, protocols to begin with. However, it's too early because Cleopatra really, scores overall at this point in time. But then I think CNS involvement, role of tucatinib, and then I think the meningeal disease, which was, touched upon through the DEBRA study and through a case which Dr. Bharat Vaswani shared. And I also have a similar patient who failed radiation and intrathecal chemo and was found to be HR, HER2/neu 1+ and ER+. And then we gave a TDXD, and within just 2 months, the patient started walking who had paraparesis. So I think a TDXD has a tremendous potential in patients who have, CNS disease or meningeal disease. And then, of course, the re-challenge with TDXD, which we started discussing yesterday in a patient who would have an ILD. I think, as I said, there are case reports where people have started with low doses of TDXD along with steroids in a subsequent re-challenge, once the patient has recovered. So maybe it's a shared decision. You have to be very careful because the patient could still develop the ILD. So you have to be very, very careful in this re-challenge. And then finally, the TNBC, in which, of course, the immune checkpoint inhibitors, especially if the CPS is more than 10, becomes the first-line treatment. You have the germline BRCA. And also, I think, if you're looking at PAL-B2, if that comes positive, I think it could be in the guidelines that you can still use drugs like olaparib. And, I think NGS was covered very nicely towards the end. And of course, capivasertib is perhaps not on at this point in time. And then you do have the issue of using SG. So I think the only thing I wanted to add here was the role of androgen receptor. So which is so readily available because I think, and the drugs, for example, enzalutamide or, abiraterone, I think there are other options because we just run out of these drugs. It's very fancy to talk about SG, TDX, all these expensive molecules. But I think we have had patients where the androgen receptor was tested and the patient was positive and did well on a drug like enzalutamide for a few months. Yes, NGS is there. I think NGS should be performed at some point in time to figure out if there is any targetable or any actionable mutation, although the chances may be less than 5 to 10%. So all in all, I think in all the categories of breast cancer, you have several options which need to be exercised in a sequential fashion after having discussed based on the guidelines, based on the data. And I think in our country, we do have the issue of economy. So I think great discussion yesterday on early breast cancer, today on metastatic breast cancer. So I think, Tarini, hats off to you and to your faculty, putting the right team for these discussions and helping us to learn more and how to benefit our patients. So with this, thank you and over to you.
Thank you, sir, for those words, and thank you for being a part of this program. And actually, the whole credit goes to the faculties and the hard work they put in to choose the abstracts and the discussions. Tarun, I want to thank him and the whole team, Gitika, Aram, and others, if I'm forgetting anyone. And lastly, I would like to specifically name and thank Sujit, who helped us get the registrations and get the students here. So with this, I thank all of you and hope to do it once in 6 months and hope all of us benefit from such programs which are non-influenced by the companies, and we can discuss what we want to discuss for the betterment of science and our patients. So have a good night, and hope tomorrow morning we'll have the congratulations message of the gold by Neeraj Chopra. With that, I close this meeting and thank you everyone.
We already have hockey ka bronze medal.
You are delayed on that thing because you are teaching students, Amit's boss. तुम पढ़ा रहे थे, हम तभी जीत गए थे.
Okay. All the best and congratulations, Tarini. Have a good night, all of you. Amazing, superb. Wow.
Bye.
Tarini sir, congratulations.
Thank you, everyone. Thank you. Okay, bye. Enjoy your night.
Thank you so much. So tech support, thank you, and kindly close the meeting now. Tech support.
Yes, sir.
Please close the meeting.
Okay.
Thank you.
Just one point, sir. I just interrupt 1 second.